Okay, so let me introduce our speaker to you once again, Dr. Dioracy Vicioso from Dominican Republic. He is a national and international speaker in the field of soft tissue and hard tissue grafting and implantology. He also runs and practices exclusively working in periodontic and implant dentistry. He graduated with DMD from Sao Paulo University in Brazil, and also attended several postgraduate courses, including advanced surgery training, prosthodontic and implant, and also periodontic as well. And he is also the member of American Association of Periodontic. And more than that, he is the top 5 young clinician from MIS Implant 360 Congress in Barcelona. So today, we will be speaking about post-extraction implant surgery. So please welcome him.
Okay.
អ្នកទាំងអស់គ្នាខ្ញុំសូមរំខានតិចប្រហែលជាអ្នកទាំងអស់គ្នាប្រហែលជាធ្លាប់ចូលរួម online webinar ច្រើនណាស់រយៈចុងក្រោយហ្នឹងប៉ុន្តែសម្រាប់អ្នកដែលថ្មីដែលគាត់ធ្លាប់ចូលរួមខ្ញុំសូមណែនាំពីរបៀបសួរសំណួរនៅក្នុង online បន្តិចជាទូទៅមានពីររបៀបនៅខាងក្នុងហ្នឹងអ្នកទាំងអស់គ្នាអាចសួរគាត់ផ្ទាល់ហ្នឹងនៅពេលដែលចប់ lecture ភ្លាមហ្នឹងខ្ញុំចង់ឲ្យអ្នកទាំងអស់គ្នាចុច function raise hand នេះដូចអ្នកទាំងអស់គ្នាឃើញហ្នឹងឥឡូវនេះខ្ញុំចុច raise hand ហើយនៅពេលដែលចប់ lecture ភ្លាមបើសិនបើមាន participant ណាដែលគាត់ចង់សួរផ្ទាល់គាត់អាចចុច raise hand ហ្នឹងទៅហើយគាត់អាចនិយាយជាមួយនឹង speaker ផ្ទាល់ហ្មងតែបើសិនបើអ្នកមួយចំនួនគាត់អត់ចង់និយាយផ្ទាល់ទេគាត់អាចចូលទៅក្នុង chat room ហើយ type ចូលទៅ question ដែលគាត់ចង់សួរចាំខ្ញុំសួរឲ្យខ្ញុំគិតថាងាយអត់ពិបាកអីហើយយើងមាន10នាទីសម្រាប់សួរ lecture មួយហ្នឹងបញ្ចប់ទៅយើងមាន10នាទីហើយយើងមាន discussion 30នាទីនៅsession ចុងក្រោយទៀតហ្នឹងហើយដោយសារតែយើងមាន speaker ពីបរទេសមកដែរអញ្ចឹងខ្ញុំសូមពេលនិយាយអង់គ្លេសតិច Greeting international participants. So earlier I was explaining how to question in this online webinar. Basically, there will be 10 minutes spare for the question after each lecture. To question, you have 2 options available here, either to ask them verbally or to text in the chat room. To ask directly, all you have to do is just clicking the hand function. But I'm trying to show the demonstration. Give me a second. Okay, I'm actually showing the demonstration right now. I'm raising my hand. Hopefully you can see it. For those who do not want to speak out or do not willing to talk, you can just simply go to the chat room available on your screen and type your question there. I will put those questions forward on your behalf after the presentation ended. So anyway, feel free to ask any question in the chat room.
Okay, sorry for the interruption, Dr. Dioracy. You may begin your presentation.
Okay. First of all, like I was speaking, thank you very much to Henry, Ling, and especially my Facebook friend, Firo Singh. We've been interacting for the past year and seeing how wonderful he's been planning his cases. And I've been just giving him some tips when I see something that it could be done better. But I think you have a very good talent, and hopefully your cases will be showing the evolution that all of the dentists have in the work. I am honored to be invited here to the Society Empowering Dentistry. It's an honor for me. I would like I was saying, I come from a small country in the middle of between the North America and South America, the Caribbean Sea. It's a small country divided in two: Haiti on the west side and the Dominican Republic on the east side. Okay, we have about 9 to 10 million people living here, and we are a developing country. Okay, so we have a lot of tourists to come to our beaches, and you are all invited to come whenever you decide to come. Okay, but always when I give some conferences, I will show my family. This is my wife and my two kids, Paulo, Luca, and this is how they've been growing. Paulo is 15 and Luca is 11. So after that brief introduction, we'll be talking about post-extraction implant surgery. What have we learned? I think implant dentistry is a very nice answer when we are losing teeth and when we have some situations where we have to replace them. But I think the most important thing is that it's not a technique for dentists that don't have a lot of experience. And I've been talking a lot about this. If we were sent by God with implants, then we will have implants. But there is no substitute better than teeth. Okay? So in the past 10 to 15 years, we've been seeing an evolution in implant dentistry. We've been showing about in all of the scientific literature what happens to the alveolar process when we take out the teeth. And when I was beginning my graduate program in Brazil, we didn't knew, or we were just learning the biology on all of the changes to the alveolar process. So this will be my emphasis on what I'm going to speak to you. You have to understand the biology and the things that are important when you put implants, especially when you take out the tooth. This is a nice article that I think it will help you all. What is the patient satisfaction and quality or the things when you see your patients 3, 4, 5 years after you put implants? What are the things that are the key to having a very nice implant restoration? Okay, especially in the aesthetic area. So the keys, and I will be talking and telling you a lot about one thing. You have to diagnose the situation that you are having. Especially, you have to think that when your patient comes to your clinic and he's telling, doctor, I want an implant, he's not telling you about the surgery, the screw, the bone graft, the tissue graft. He is telling you about to replace the crown. And you have to understand that implant dentistry is a science of oral rehabilitation that begins with a surgery. Patients don't ask you to have the teeth extracted. They don't want to know if you have to graft or not. They want to have a tooth that looks just or equal to the one they are going to lose. So the first thing is you have to have a plan, especially a prosthodontic plan. You have to know the correct position of the implant so you have a good, nice restoration. You have to see if you have a quality and volume of bone and soft tissue, so you don't have a bump in the transition that comes from the implant to the crown. So the most important thing that you have to take about is if you have bone, if you have soft tissue, and especially if you are doing a single implant in the aesthetic zone, is that you have to have interproximal bone. If you see a bone loss, this will tell you that maybe you have to take the surgery or delay the implant placement and first do the soft and hard tissue graft. Also, you have to know the specific shape of the root and the interface with the crown. Teeth are not cylindrical. Teeth in the anterior zone are in the shape of a triangle. So you have to mimic specifically the shape of the tooth that you are going to replace and develop the emergency profile as the shape of the tooth you are going to replace. So this are the key things you have to take in mind when you are planning a post-extraction implant. Many things you will see when you see patients refer to you, and especially in the anterior zone. This is a typical case where you see lack of planning, lack of understanding the biology of what happens when you take out a tooth and you put in an implant. Things that you will see is loss of marginal and soft tissue, especially in the marginal area. And this is very important that you plan or diagnose the phenotype of your patient. If you have a thin biotype, you will have to make changes to your planning, especially depending on the type of bone loss that you will have. If you have a vertical or a horizontal, you have to change the placement of your implant or not to put the implant. This is another case, typical case, when people don't develop the emergency profile of the patient, and you will have these kinds of situation when the crown doesn't adjust perfectly to the abutment, and you will have plaque accumulation, you have mucositis, and then perimplantitis. And especially you have to have a good technician. Because of what? Because if you know how to plan, if you know how to do the surgery, if you know how to do the soft tissue, the hard tissue grafting, and you don't have a good technician, all of this won't be sufficient to have a long-term or a good-term prognosis on your implant, on your implant restoration, especially if you don't have platform switching implants, if you don't have an emergency profile specifically to the tooth you are going to replace. And this is a very important paper done by my dear friend Mauricio Araújo. And this paper is very important for you young denticians to know and understand what happens to the bone when you take out the tooth. If you see here, you have a lingual plate and the buccal plate. And in 8 weeks' time, if you do not do nothing, if you don't do socket preservation or do implant or anything to compensate the bone loss that you are going to have, you are going to see that this is the initial bone. You see that the bone is on the level, okay, here. And in eight weeks' time, you see that the bone has a change in the vertical position, that it's determined by Professor Kahn, Professor Berzer, and all of the good scientific paper, that it's going to be a change of about 1 millimeter. This is very bad when you are trying to develop a transitional zone that you don't see if you have an implant or you have a tooth. So why does this happen? It happens because that thin plate of bone is about 0.3 to 0.8 millimeters in width. And when you take out the tooth, this is the alveolar process, you will see here that you have the sharper fibers that are going to be inside the buccal plate and in the dentin or the cementum. And when you take out the tooth, you are going to take out half of the buccal plate. And this is what Professor Mauricio Araújo called bundle bone. This is why the buccal plate collapses inward, and you will have this bump in the area where you need to be more at the level to the teeth that are besides your implant. This is why we are going to tell you what you can do to not have this kinds of problem, or to minimize the changes and in the time frame that you put your implant in. So another thing that you have to take in mind when you are planning an implant in the post-extraction way is the type or the inclination of the roots. This is a very nice paper made by the team of Loma Linda. For me, Professor Joseph Kahn is one of the leading scientific and clinicians showing us the way to go in the post-extraction implant dentistry. And he divided or classified the positioning of the roots depending that is if the root is going forward or it's going backwards, especially class 1. If you have this situation that is usually 86% in the central, you will have no problems putting your implant. Remember that you are going to put your implant buccally, not in the palate, not changing the emergency of the implant in respect to the crown, okay? We have been showing by the papers from Dr. Mariano Sanz and the Complutense University that the forward you put your implant in, the bigger problems you will have. Because of what? Because of the reshaping or the resorption of the bonded bone. So when you are planning a post-extraction implant, you have to make good diagnostics, and you have to have a cone BCT, so you plan specifically the position of your implant on respect to the buccal plate. These were my all cases showing what we did and what were the problems that we were having when we follow up our patients on the long run. This is a fracture of the central incisor, the right central incisor. So in that time, we didn't knew the correct protocol to manage these kinds of cases. So we took the protocol that we were doing like 8-9 years ago. We did an extraction, very less invasive extraction, using nice instruments, very fine instruments, and we took out the tooth, okay? We see that we have the buccal plate present, and this is a very nice picture. If you see the little white point more to the buccal plate, this is the position of the apex of the central incisor. You never put your implant over here. You incline the base of your burr and to engage the palatal bone. Not to put the implant here, but put the implant in a position that is engaging the palatal bone and not changing the emergency of your implant. This is why post-extraction implant is not for the new practitioner. It takes time, it takes good diagnostics. So we put the implant, we make the gap, like Dr. Turner says, 2 millimeters or more. We fill the gap with a xenograph. We put the final abutment, torque it out. We did a provisional restoration. My provisionals weren't very good in that time, and we finish up the case. Very nice platform switching, conical connection. A very important tip: you have to use an implant that has expanding shape of the screw. Why? Because the first thing in immediate loading is that you have a very nice initial stability. You have to have at least, for me, 35 Newton centimeters. 45, it's very good. 55 is nice, and more than that, it is not good. Who is writing on my presentation over there? So we put the implant in. This is the 15-day post-op. This is the 4th month post-op, and you begin to see changes that we, on that time, we didn't knew how to look to our patients. You see aquí a blackish situation. That's why, because the tissue is not enough. The tissue is not thick enough. So we took a final impression. Never do this. This is a big mistake that I did, to put retracting cord to take an impression. And my dental lab made a zirconia with stratified ceramics, and we have a nice transition. But if you take a look and you compare the left side with the right side, you see a dimpling, you see a reshaping, you see a remodeling, and you see a grayish transitioning of the abutment. So I thought I was doing a very good job. And 4 to 5 years later, the patient called to my office. The things that any dentist wants: a call from an implant patient then telling me, doctor, I want to take a visit and I want to show you something. I got very scared. I thought the implant, it was with pain, with something got wrong with the implant. So the patient got in and we see the X-ray on final cementation, and you see that everything, it's good. Everything is in place, okay? Nice bone over the bone, no micro movement, no infiltration over there. So I thought I was doing everything right. The patient came back and you see what happens. You see a deep a collapse of the bone, a collapse of the soft tissue. And this is showing me that my protocol on that time, it has to change. And it is not a thin biotype. I think it's an intermediate one. And this is a lesson learned, okay? If you see another case, in same type of implant, same type of abutment, a metal ceramic crown on a friend. This is the Combin CT. You see nice bone, very nice transition, very nice emergency profile, very nice crowns, and everything is good. And because I wanted to show you this case in the molar area that we can do post-extraction implant, this is for me the most difficult place to put an immediate loading implant. I wanted to show you some pics 6 years from the day I put and cemented the final crown. Because of the COVID, I couldn't take the pictures, so I talked to the patient to send me pics from the cell phone. And if you see here, you see the same thing. You see the collapse of the bone, you see the collapse of the soft tissue, okay? Specifically on the marginal side, exactly like Dr. Mauricio Araujo told us. So, if I continue, I can show you 10, 15 more cases exactly like this. So, the most important thing is to know why. Why does it happen? If you have an thin biotype, in 4 months, you will lose almost the entirety of the buccal plate. If you have a thick biotype, you will see little changes. This is a very nice paper done by the Swiss group of Dr. Daniel Buser. And this is very interesting. You see here, you will see more than 50% bone loss on thin biotype. Specifically, if you have triangular shaped teeth, this is a correlation usually with thin biotype, thin tissue, thin bone. And when you have a thick biotype, you will have like 20%. These are the cases that usually you will have less changes in the long-term run. And this is the another paper, a very interesting paper made by the group of Spain and Sweden, Professor Mariano Sanz and Professor Linde, showing specifically the same stuff. If you do a flap, this would give the resorption will be bigger, especially in the anterior area, but you have the same bone loss in premolars, molars, okay? Specifically if you have a bone loss. In vertical loss of about 0.5 millimeter, exactly like the paper from the group of the Swiss group, and about 1.5 millimeters of bone in the vertical way. And specifically, if you put the implant forward or to the buccal plate and the resorption comes, you will have very difficult problems to change the soft tissue problems that you will be having. And what is the new protocol? And this is very interesting because in 2007, specifically to the research of Professor Khan in 2003, we began to see that we had to modify our protocols. That not only that we have to put the implant in the correct position, that we have to have a very good bone in the middle of the buccal plate and the implant surface, that we have to have something else. And this something else was a soft tissue graft. This is very interesting. Seeing here that if you have more than 2 to 3 millimeters of thickness on your buccal tissue, the changes of the materials will be less. Okay, if you put zirconia, if you put titanium, if you have more than 2 millimeters, I think 2.5 to 3 millimeters is the perfect thickness, so you can have a metal ceramic or a zirconia restoration. So this is one of our cases. This is one that is part of our clinical trial in our university. This teeth is going to get out, is fractured, it's central incisor. You see that you have a medium to thick tissue. This is the occlusal view. You see that the shape of the root, it's the same to the other teeth. And this is what I want you to see. This is what we are changing in our post-extraction protocols. And the most important thing, if you have to change the way you do extractions, we usually on our universities, we've been taught to do extraction with this kind of elevators. This is elevators for the third molars. If you want to do the less invasive, the less traumatic extraction, you will have to change to this kind of elevators. In the shape and the way, thinner, to enter the space of the periodontal ligament, and not in a perpendicular way. You have to go parallel to the teeth on the palatal side and gently and with patience to luxate the crown out. So we took out the tooth, we put the implant in the position. We like to put the implant in our cases, specifically in the central incisors that screw hole comes not only on the singular, but in the middle of the singular and the incisal edge. Because when you see the images of your teeth, you have to put it on a way that you get away from the buccal plate, that you have enough space so you can put your bone substitute as a slow resorbing bone substitute, a xenograft, a allograft on the space, and then to put a tissue graft specifically on this area where you are going to have the collapse of the soft tissue or the bone. So very important that you have the instruments, that you have the things that could help you to do the space that we are going to do. This is the knives that we are having. This is the regular 15C blade, and you see here very small very delicate instruments, so you can gently do a pocket between the buccal plate and the periosteum. So you can, with all of these situations, this is the Vista periosteo elevators. This is a very nice one that I use a lot. Okay, so we can enter and gently make our pocket for our soft tissue graft. So we go ahead. This is another one. This is the Viper. This is a blade made in France. The name of the brand is MJK. This is the Viper blade, and we gently go with magnification. You enter from the mesial to the distal, and you get to do a pocket. So you go to the palate. This is the Professor Giovanni Zucchelli from the University of Bologna. He developed the gingival, the soft tissue grafting, but specifically the free gingival graft, that you take out the epithelium from the mouth and from the top, and you get to the lamina propria. Lamina propria is the most stable tissue, so you won't have a very too much changes or too much shrinkage on your soft tissue grafting. And this is a very nice paper that tells you a comparison. If you take a free gingival graft, the trapdoor technique on the palate, a 2 to 3 incision on the palate, and the Professor Bertel Langer's technique in 1985, a 1 incision, okay? The bleeding with the gingival graft is more than the lineal, and the discomfort depends on the ability of the surgeon. In my case, I've been doing this technique for the past 5 years. If you don't engage the deeper parts of the palate and you take out about 1.5 millimeters, that's enough of the palate. Or if you go to the tuberosity, the post-operative pain and the post-operative bleeding is lesser if you go to the deeper parts of the palate. And this is very interesting. This is a paper that if you take it, your graft from the palate, from the middle part, you will take about 50% of fat tissue or glandular tissue. But if you take it near the epithelium, you will get a more fibrous connective tissue. It means that you will have less shrinkage and less changes, dimensional changes in the long term. And this is what the conclusions of this interesting paper. And this is one of the many soft tissue grafts that we are taking from the palate. You see a very nice same width in length and in height, and you see that you usually will, with 1 to 1.5 millimeters in thickness, you will have a very nice soft tissue grafting that will integrate nicely to your implant plates. Okay, so this is very interesting. You have to be careful with the emergency of the greater arterial palatal greater artery of the palate. Usually, if you measure from the distal part of the second molar to 10 to 12 millimeters, you will have an idea where is the thicker part of the artery. When it goes to the front of the palate, this artery will decrease in width, and you will have not a lot of changes to have some bleeding of the palate, post-operative bleeding. Okay, so this is the thickness. You will see that about 10 millimeters, you will have the greater artery, and you see here the thickness of the palate. This is the two places that we usually take our graft in from the canine to the first molar. You will have the thicker part of the palate, but it has a lot of fat and glandular tissue. And Professor Iñaki Gamborena, he likes to take out the tuberosity and this area over here. But this is more difficult. This is for experienced surgeons, but it's a very nice tissue if you want to have a lot of thickness. Okay, but be very careful, because the papers are showing that in 5-6 years we'll have developing a volume more than the place that you are giving, because of the phenotype of the tuberosity. Okay, so you have to be very careful when you take out these kinds of tissues. Okay, so going ahead, usually putting our implant to the buccal plate, taking our tissue, desepitalizing outside of the mouth with a nice blade, using a provisional metal abutment. And this is a interesting provisional. We take a silicone impression of the patient before the surgery. We send it to our lab. The lab makes us a PMMA crown, and we just put flowable resin. Okay, we fill up very nicely the bone graft. Okay, and you see here that we suture our soft tissue with tiny polypropylene sutures, 6-0 or 7-0, recognized by Professor Marco Hutzler and Otto Suhr from Munich. So we do flowable, and we make our critical and subcritical contour. This is very interesting. Some of my errors, it was trying to imitate the same space as the teeth. You only have to manage the critical contour. This situation over here. This is the most important thing that I am going to teach you today. You will have to know the thickness of your soft tissue. You will have to know the position of your marginal bone. And we prefer, we've been seeing in the literature, they use implants not with hex, but with a conical connection, because we will have less micro movement. We will have less bacteria in the interface between the abutment and the platform of the implant. And you will have enough space, about 3 to 4 millimeters, to manage the critical contour. This is the most important thing. And you have a concave situation to make space for the soft tissue and to make our transitions as better and as imperceptible on the anterior and posterior areas. Usually, this is very important. You will have to have enough apical bone so you can anchor your implant and have very nice initial stability. So we shape the emergency profile, we shape the critical and subcritical contour, like the very nice article from Professor Sun and Nestor Lee in 2010 from the University of Pennsylvania. And we try to use not cemented provisionals. We like to use screw retained provisionals because they are more stable, and you will manage perfectly the post-extraction situation. So this is the final provisional restoration. The patient goes home, and this is a 3-month follow-up. Why 3 months? Because in 3 months we know from scientific papers and from histology that the connective tissue is stable enough so we can take out the provisional and don't have many more changes on our emergency profile. This is the X-ray. You see very nice here the over contour of our soft tissue. This is a very nice emergency profile. You have the very good position of our implant. You have you have bleeding of your soft tissue. This is not bad. This is the insertion of the hemidesmosome on this surface of the composite resin. This is very important you to know. If you have any surface, if it's clean and polished, you have very nice results. This is the millimeter where you have plaque, and this is the thing that you have to manage on your long-term prognosis. This is all information, and a very nice book so for you to read is the zero bond loss concept from Thomas Linkevicius of the University of Vilnius in Lithuania. So very interesting to have to send the correct information to a lab technician. We'll do a personalized transfer. Okay, we usually use these kinds of abutments, the T-base, that you can change the apical to coronal positioning, and this is because we are going to do hybrid components. Okay, we did a zirconia abutment. We did the class 4 restorations. You see here that the emergency of the screw, it's in the incisional edge. In that time, we didn't have the dynamic screws that we have now. Okay, and this is a very nice paper, so you can see the different materials and the reactions with titanium, zirconia, gold, and gold with ceramic. Okay, the best restorations that we think we're having today are the polished IMAX, and the better ones are the titanium or the zirconia hand polish, because the polishing is very important to the contact to the emergency profile. And this is same stuff. You have to think that zirconia to ceramic, it's a very interesting case. It's a very interesting situation. If your lab doesn't work the temperature when he applies the ceramic to the zirconia, you will have tension on the surface. The ceramic would get colder faster than the zirconia inside, so you have tension in the bonding area between zirconia and the ceramic. This is one of our cases, a 10-year follow-up. When you have abutment zirconia, you see chipping over here, but you see very nice emergency profile. So this tells me that zirconia is a biologically very important material to use in contact with soft tissue. Okay, this is a 10-year follow-up with the hex, and you see here that we didn't know on that time the shaping. The concave shape, and you see very little resorption on a hex implant. Okay, so this is the lessons that we've been learning in time. Okay, so continuing on, we see that zirconia will have some shipping, but the response to the soft tissue is very interesting. So we did a abutment with a lithium disilicate crown, and the lab technician did ceramic application to make the bonding more efficient. We liked to do these kinds of restorations. You see that the limit of the preparation mimics the shape of the critical contour. And this is the way my dear friend Victor Clavijo told me to cement with abutments. Do total I forgot to say it in English. You put a rubber dam, okay, you screw you make the holes, and you screw your abutment through the rubber dam, and you will have the inversion perfectly, so you have a very nice surface, clean, and you will see the excess of cement. Now you can bond perfectly to the ceramic, bonded to the tooth. And my cases are not perfect. This one, the value is a little different, but the patient didn't mind and he loved it. So we have very nice contour. We can see any of the excess of cement. This is immediate after cementation, and you will see the nice vestibular marginal over contour. This is why I teach you today. If you don't see me anymore and you get in mind, when you do post-extraction in every position of your mouth, this is the protocol the literature is telling us to do. You see very nice integration of papilla. The margins are in shape. The bone is in almost perfect position. And this is a 1-year follow-up. You see that your implant is much better than the tooth. This tells me we are doing stuff the correct way, the biology way. And doing a recap of this information, this is a summary of what you can have. This is a very nice article from the Loma Linda group, that immediate implant restorations improves the aesthetic results, that you cannot do flaps. If you do flaps, you will have more bone resorptions, that you have to fill this gap between the implant and the buccal plate with something that slow resorb. Xenograft, allograft, especially in thin biotypes, you almost, in my opinion, and I see all of my friends, Gustavo Giordani, Professor Eric Bandura, and Professor Nitzan Bichacho, in almost all of their cases in the post-extraction implant, they do this kind of protocol, bone and soft tissue grafting. And this is very important to select your patients, because if you have not compliant patients, you will get in trouble. And it's for me to say here that you have to develop your surgical skills so you have a very nice result on the long run. And a summary of the biology. This is just so you can take a picture. This is specifically the histology and the dimensions of the emergency profile, just for you to have, and you can read those 2 articles that are very interesting, Professor Berglut and Professor Lisgarden. from like 20 years ago, more than 20 years ago, explaining all of this. And this is the same stuff telling us that if you do soft tissue grafting, in the long run, you will have more better aesthetical results. Same stuff from the group from Loma Linda telling us that if you do soft tissue grafting, you will improve the maintenance of the gingival level on the long run of your post extraction implants. This is a same case, a female patient that came to the clinic with a fracture, always seeing the cone beam CT. This is the mesodistal fracture, and we did the same protocol: extraction, implant in an incisal singular position, bone grafting the graft, and soft tissue grafting from the palate, like Professor Sukeli told us. This is the 3 months follow-up. You see that if you have square teeth, it's much easier to have papilla and have more stable cases. Always using a screw retained provisional. This is very important. This is another article comparing soft tissue to allografts and telling us that allografts, you will have about 50% resorptions, and if you do soft tissue grafting, this will be more interesting for you. This is a very nice paper from Professor Daniel Thoma and Professor Ronald Young from the Swiss group. Same stuff. Look at the very nice soft tissue over contouring, very nice health, very not bleeding of our sulcus. Same thing, impression, zirconia abutments. In that time, we didn't have the dynamic screw. I think all of those cases will be done screw retain. We usually put a little bit, and this is what another tip. You have to clean your screws. You have to clean your crowns. You have to clean your abutments. In an ultrasonic bath, Professor Luigi Canullo has a very nice article in 2012, and he tells us to put in a ultrasonic bath for 10 minutes in a cleaning detergent, then pass it from ethanol, 10 minutes, and then you pass it through acetone, and this will clean any debris, any remnants from the laboratorial process, and you will have a very nice clean screws and clean restorations. Okay, I put a little bit of chlorhexidine. We screw the abutment. We cemented it. We did the class 4 on the central left incisor, and you have these situations. At the day of cementation, very nice bone in the interface between the abutment and the implant. This is an overview, always emphasizing the over contour of your soft tissue on the buccal area. And this is a 1-year follow-up. Very nice results, very stable results. Okay, and you see a cone beam CT. And we are doing cone beam CTs 2 years later and measuring. And you see very nice here that you have 2 millimeters, 2.5 millimeters, 3 millimeters on the gap. This is why we try to use implants that in this area you have a flat shape, because you have more space for bone to be there. And if you do a cone beam CT, and when you do the cone beam, you separate the lips, you will manage and you can measure specifically the soft tissue. And this is very important because all of the things that we are showing is our cases stand the criticism of the scientific literature. 2 to 2.5 soft tissue, you can put whatever abutment, metal, titanium, zirconia, lithium, disilicate, or gold, and you would not see any translucency. This is the final smile. The patient's it's satisfied, and we are satisfied. Our cases, central matches are very difficult, and you have to have a very nice and very good communication with the lab technician. How we are doing with time, Dr. Henry? Hello.
I think you can still have 15 minutes.
Okay. So we are going to continue. And this last case, this last case on the post-instruction single implant, just to show that if you do this sequence, okay, extracting the implant very nicely, put the implant in a palatal way, not changing the emergency of your screw in relation to the crown. You see the gap that Dr. Charnel always told us, more than 2 millimeters. It's enough. Filling the gap with bone, a slow resorbing, and I specifically love the soft tissue. Soft tissue is the key in the post-extraction implant. And you can see this over dimension. And I will be more glad, I will be more at ease in the follow-ups of my patients. That if the bone resorbs, if you have remodeling, this over contour will have a very nice situation on the long run, preserving the same shape that you have in the time that you put the implant in. So this is the message for you, okay? This is the final restoration. This is same stuff. Always trying to see this bone of more than 1 to 2 millimeters, infra-bony placement of the implant, 1 to 2 millimeters, a conical connection, an implant with the geometry on the neck of it, okay? The smaller the implant, the better. Filling of the gap and a soft tissue. And you see here 1 to 2 years later, you see how nicely the critical contour, the concave of the abutment lets the soft tissue stay in place. You have a thick tissue specifically in the transition of the bone. This is the most important thing. Let me exit my presentation because I have a little time. I wanted to show you another way that you can manage the post-instruction implant, okay? This is a situation that I did with a friend of mine. I put an implant over here a long time ago. And this, when I didn't know how to do prosthodontics, okay? So he came back, he didn't have a lot of money. And I told him, well, this is a new technique. And I usually try to do new techniques in patients that are close to me. And I told him, I'm going to do something new. I don't know if it's going to work, but it's going to be free for you. So I wanted to do a PET technique, a partial extraction technique or socket shield, described by Professor Michael Hutzler and Otto Suhr from Munich. And this technique tells me if you leave a little piece of the tooth, specifically on the area that is going to collapse, okay, you can lie to the bone to tell him that the tooth is still inside the mouth. The mouth, and this is an article that's called proof of a principle. We did the same situation. We put the implant in. We put a very 2 millimeters infrabony. The technique is to leave a piece of the tooth, and you have to grind it at the level of the bone. Then you do a provisional restoration. We do flowable. We did a composite, and I did an ugly restoration for my friend. Excuse me for that, but in that day I wasn't paid too much attention, and he was glad. And this is the thing, 4 months following up, a little bit of a show through of the teeth. And this is one of the complications that you can have. If you don't have suppuration, if you don't have a movement of the piece, there is no problem. Why did I did this? Because here I have an implant, and here I was going to take out the tooth. And this papilla for me was the most important thing. And I know if I take out the tooth, the compromise of the papilla will be greater. If I do it today, I would leave that piece to come to the interproximal space to maintain my dimensions of the soft tissue in this A position. I will tell you, this is a very difficult technique. This is a very highly skilled technique. And if you don't have the instruments to do this, I prefer you to go slowly. And when you have enough experience, try it, okay? It has 10-year follow-ups. You have very nice scientific follow-ups. Professor Howard Gluckman from Cape Town, South Africa, Professor Maurice Salama, they have a lot of experience and papers showing that stability of this. I only have 2 cases that I'm going to show you. And what we did, we take the final impression, we grinded out that little piece of teeth. We took an impression, a normal analog impression. And we did a monolithic lithium disilicate press, screw retain. You see here that we did the glaze and the makeup from the critical contour up, and we polish hand very nicely from this subcritical area. This is very important because if you have ceramics, if you have rough surfaces over there, you will have some problems on the long run. This is the final restoration, a little bit of a retraction of the implant, but our papilla is it's stayed in that position. So we see here the implant and the integration. Nothing of bone loss or very little loss. This is the clinical sequence, the prosthetically driven implant placement. And this is a 1-year follow-up showing a con-BCT of the integration of the implant very nicely. And this, I don't know what it is. Maybe it's bone, maybe, I don't know. But it's stable, it's the soft tissue, it's not bleeding, and everything is in position. This is a very interesting technique for you to maybe do when you have more experience. So we did another one, a young patient that broke a premolar. We did the same stuff, took out the root, left a piece of the vestibular root, put the implant in, put the implant in, did a provisional restoration, a composite restoration, maybe by hand, screw retain. The patient was studying in England. She went to England and came a year later. And we see very nice integration in the convexity. This is the immediate post-op, 2 months post-op, and then she got back to England. Nice integration of the soft tissue. You see the nice evolution, and practically no changes in the buccolingual direction. Okay, so we did same stuff. We did a lithium disilicate crown, screw retain. And this is why you have to have a very nice lab technician, because the patient don't see your nice screw, your nice implant, your nice soft tissue, your nice graft. He only see the tooth. And if you don't have a very good technician, you will get in trouble. And this technician understands the biology and the biomechanics on the materials and the situation on the mouth. And this is the thing that I like when you put your crown in and you see the critical contour accompanying the soft tissue contour very nicely. And when you take it to position, you see that the restoration disappears from the mouth. This is why we are very particular, that we are very passionate on the things that we do, and we like to do the things biology driven and prosthetically driven. And the selection of the material, the selection of the implant, the selection of the technique is very important for the long-term run of your cases. And when you begin to see your errors, this is where you learn. You don't learn when everything goes well. You learn when you sweat, when you learn when you get in trouble, when you have pain. This is the thing that makes you read, that makes you get the information so you have very nice results. And if you see from the occlusal plane, you will see that there is a very nice transition, very good papillas, very nice dimensions of the soft tissue, and no changes in the vestibular palatal way. We need more long-run cases. We've been following our cases for 5-6 years, and the changes are very small. Okay. So, finish up my presentation, because I have a lot of material. We don't have time to speak, to put 2 implants side by side. This is another webinar that we can do, explaining the pros and cons of this, but because of this, we don't have time. So continuing with our case and the final 2 cases, can we do this in the posterior area? We can do it. And remember that I show you one in the lower jaw. This is one in the upper jaw. And you see the thickness of the patient. We usually take out molars. If in the upper jaw, we split it in 3. If it is in the lower jaw, we split it in 2. Okay, always doing a comb CT and showing the interceptum. If you have a very nice interceptum, you can put your implant in. If you have a very nice torque, you can do a individualized healing cap. This is the way of going, not to change or to displace the margin and the mucogingival line over this. This is not good. I prefer to maintain the things the biology is telling us, exactly the shape of the tooth that we took out, and we copied exactly that, and we did the same stuff, the same steps to communicate with the lab. We always do screw retain. We like to do a lot of lithium disilicate press with a very nice makeup of the crown. And this is a 3-year follow-up showing a very good long-term run. You see no changes on the marginal tissue, and you see that we have very good integration, very good planning, very good surgery, and the communication with our lab. Okay? And you see here that not always we forget to put the implant in the lengthwise. Sometimes this happens. I forgot the day of the surgery, the length, and I put the implant in. The implant went very well. No pain, no problems on the follow-up. And when I did the COMB-CT follow-up, I saw this. This is not to do, but the scientific literature tell us that if you have a clean sinus and you get 1 to 2 to 3 millimeters inside, and you have very nice initial stabilization, there is no problem. I am not telling you to do this on all your cases, but if something goes wrong and everything is good, there is no problem. This is a very interesting thing that I want to tell you. The inclination of your abutment restoration is very critical. If you do 90 degrees, you will have dead spaces where the patient cannot clean. And if you put pressure on the soft tissue with your healing caps or with your abutments, you will begin to have a bone loss around your interface with the implant and the crown. So this is very important you to know when you are doing your provisionals, when you are doing your surgeries, and when you are doing your final restorations. Okay, this is a good article establishing the angles of the prosthetic driven restorations on respect of bone resorption and soft tissue stability. And my final case, where do I think that we can improve on the things that I've been showing you today? One of the things that I learned from my first 2 cases is that if you see the concept of the one abutment one time, it's a very interesting theory. And it's very interesting because you see the x-rays following up, that you have 0 to no bone loss, and you have overgrowth of your implants, of your bone over the implants, and almost in contact to the abutment or the surface of the abutment. It tells me that there is no micro movement. That's why I try to use as much as possible conical connections, that you don't have migration of bacteria in the interface of the abutment and the implant, and that the bone is stable enough to grow over your implant, and that you have a platform switching system. But the problem that I see on the first cases that I show you is that you cannot have a screw retain restorations. And if you can have the same principle of not removing your abutment a lot of times, because we know the less we move the abutments, the healings, the transfer, and the crowns, the less movement, the less bone resorption we will have on our implants. So having that in mind, this is a systematic review showing that if you disengage provisionals or implant final restoration, it's been showing that you will have less bone resorption. This is our final case. This is a very difficult situation because this is the wife of a friend of mine, is also a dentist, and is a patient that didn't want to go out of the clinic without a tooth with a removable prosthesis. This is the situation, a thin biotype. We have bone loss on the distal part. We see on the cone beam CT that would have partial resorption of the buccal plate. And if you see a specific imaging, you see that you have bone loss between the lateral and the incisor. I talked to the patient. We strategize on the different ways to treat this patient, and I tell you, this is not the way I want you to treat your situation. This is a very difficult, very highly skilled, that if you don't have the skills to do it, don't do it, because you will get in trouble. But because it was a patient, a friend of mine, a dentist, I told him the pros and cons. And the pros and cons you all know about it. So you say, don't worry, I trust in you. I hate when people tell me I trust in you. And whatever happens, I know the clinical consequence, okay? So if you see a occlusal view, you see that the problem is not the mesial, it's the distal part, and you see that you have bone loss. So what we did the extraction. It was a breakage. The patient, when she was 10 to 12, got a fell, and she had many crowns done, many introductory treatment, and now she's 40, and the tooth, the root collapsed. Okay, so what we did the same stuff. We put the implant in the correct position. We did with the special instruments. We did a gap. We did our pocket. We did our graft from the palate, 1.5 millimeters in the diameter. Okay, 15 millimeters by 7. And this is the nice developing, or the thing that I'm going to show, the way that I'm doing my cases today. This is a platform. This is the connect abutment from MIS. This is a block. You don't have spaces. You don't have screws. This is a block. You don't have moving pieces. So this is a platform that you put on your patient, and you will work from the platform up. You don't work directly on the implant. And my dear friend Pablo Galindo from the University of Granada has a lot of papers talking about this. If you put the platform of the implant and you go upwards, and you put the situation where you can remove the provisional, the transfer, the healing, and not to be in contact with the bone, this is much better for the graft, for the soft tissue and the bone. So you torque it, and this is the provisional abutment that screws on top of it. And MIS has 2 kind of abutments, a conical connection. This is the old one that you have a triangular shape, and this is a octagonal that you have 8 positions, so you can better manage your situation. The pros and cons. The pros, that you can work from, not from the platform of the implant, but above of it, usually 2 to 3 millimeters. And the cons is that if you don't have enough space to manage the critical contour and subcritical contour, you will get in problems because you will see the platform of the connect. The way I use it, if I have 4 millimeters of emergency profile, I use a 2 millimeter height connect. So I have 1 to 2 millimeters to manage the critical and subcritical contour. Same protocol, soft tissue, provisional restoration. I did this one in a direct composite. Very important to shape your provisionals, to shape the critical and subcritical contour, and to have a screw retain restoration. This is the provisional. Day or 2.5 hours later. This is the 4-day follow-up. Very nice plump tissue. This is a hematoma that is usually in patients that when you do a soft tissue grafting, the blood and the coagulant stays over there and you will have this kind of situation. This is not important. This is the X-ray. This is the 14-day follow-up. Very nice, very good integration of our provisional restoration. You see the overgrowth of soft tissue. And this is a 3-month follow-up where you see a nice shape, a nice contour, a nice provision, a nice emergency profile of papillas, and it's ready to have final impressions and do final crowns. This is the X-ray. You see here very little to no, very little bone resorption. Remember that this here was in this position, and this, I think, with time will fill up. And you see here that we put the platform of our restorations here, not over there. This would help a lot on your cases where you want to reduce the bone loss on your implant. This is a very nice solution, and you can take this out as many times as you want, not to damage your connection to your implants. So this is the thing that I think will help you in on managing your post-extraction implants. So in conclusion, in resuming our lecture on these topics, you have to know the biology. You have to know that you have to manage specifically the biologic width. You have to have very good quality of the bone and the soft tissue. That if you have thin tissue, you have to manage it with soft tissue grafting. I prefer, and I think, not to use xenograft or allograft of the soft tissue kind, because you will have a lot of collapse, soft tissue from the palate or the tuberosity. To plan the position of your implant in the correct way. This is planning your case before, talking to your restorative dentistry if you don't do your crowns, talking to your lab technician on managing the positioning of your implant. This is very important. And for me, you have to develop your skills. You have to develop your instruments to help you and to make you more comfortable when you try to do these kind of cases. The post-extraction implant is a very difficult treatment planning that we almost, and our patients are wanting to have. But if you don't have the knowledge enough to do your cases, you will get in trouble. Okay, so this is my final statement, and for me this is the best slide. This is my university in Brazil, here, okay? This is all of my mentors, all of the top graded professors that have been telling me and passing my knowledge to them. I encourage you to get the very top knowledge, the very top educations, because this is the only way you can go forward. I had a long time ago, and I don't think who this is because I was so thin. This is the original or the clinic of Professor Branemark in Gothenburg, Sweden. I had the privilege to see it, to speak with him, and if it wasn't from him, I will not be talking to you today. This is my professors. This is the professor of Mauricio Araújo before he went to Sweden to teach and to learn from Professor Linde, and he was the same professor that taught to me 16 years ago. So for me, it was a pleasure to be speaking to you. I hope if my information and my lecture would be beneficial for your treatment planning and your success on the long run. If you have any questions, if you want to follow me on Instagram or Facebook, be free. I usually post tips and stuff about implant dentistry. Thank you very much for your attention.
Thank you so much, Dr. Dioracy. And now we open the question for the floor. Any question from the floor? ពួកយើងមានអ្នកគេមានសំណួរឲ្យអត់ចង់សួរគាត់ផ្ទាល់ហើយបើសិនបើសួរអាចលើកដៃបានណាហើយខាងក្រុមការងារគាត់នឹងអានម៉ូដអ្នកទាំងអស់គ្នាព្រោះឥឡូវហ្នឹងគាត់ដាក់ម៉ូដមួយដែលអ្នកទាំងអស់គ្នាអាចអានម៉ូដខ្លួនឯងបានទេអញ្ចឹងតតែលើកដៃបានពួកខ្ញុំអាចអានម៉ូដអ្នកទាំងអស់គ្នាឲ្យសួរគាត់បានមាន participant ម្នាក់គាត់លើកដៃចង់សួរអត់ទេបងខ្ញុំឃើញគាត់លើកយូរហើយហ្នឹងប្រហែលជាគាត់អត់តម្លាក់ដៃចុះវិញគាត់លើកបាន participant ហ្នឹងលើកតាំងពីដំបូងបងហ្នឹងហើយឥឡូវអញ្ចឹងឆ្លៀតពេលហ្នឹងខ្ញុំសួរសំណួរក្នុង chat សិនណាហើយបើសិនបើណាគេចង់សួរអីចាំលើកដៃតាមក្រោយ So alright there's two questions we got from the chat room. So one okay, so no. Please keep going.
No, I was trying to make a joke.
Okay, so one question he would like to ask, what do you deal with the buccal side collapse? How do you negotiate with the patient, and what is your management toward the buccal side collapse?
This is a very, very, very good question. So, you can follow two ways of thinking. You can follow the Swiss way of Professor Buser. If you have more than 3 to 4 millimeters of bone plate resorption, you will have to manage it on stages. Okay, this is doing soft tissue grafting or waiting 6 weeks, open a flap, put the implant, and doing a GBR technique. Okay, I think this is the safe way for a young implant dentistry. Because of what? Because you can manage your stages. In my case, I manage partial resorptions with no problem. But you know that you have to have a lot of skills. Usually, I talk to the patient. I show him my very good cases, and I show my very bad cases. And I tell him, if you go this way, we can manage it, and we have a 60, 70, 80% chance of very nice prognostic. But if everything goes bad, this is what happens, okay? So you have to speak to your patient. You have to, with scientific papers, tell him the pros and cons. This is a big mistake that I made when I was a young dentist, that I thought I didn't have to speak to my patient. And the problem was that I took all of the risk myself. And when things went wrong, I had all the blame to me, because I didn't understand the biology and I didn't understand my skills. Okay, I didn't have skills enough to manage those cases. I usually, in almost all of my cases, do immediate loading. If you have a complete resorption of the buccal plate, I don't do immediate placement. I don't do post-extraction. I do soft tissue grafting. I let it heal for about 3 months, and then I see if I have a horizontal or a vertical defect, and I manage it with the patient. The thing is that usually when you do on stages, you have usually 1.5 to 2 years of dental treatment. And I put in a balance 2.5 years or 2 years, maybe 4 to 5 surgeries to have our cases. Maybe I can show you my cases where I do vertical and horizontal regenerations. But when you do all in one stage, you can manage the emergency profile much better. You can compensate the dimensions of the tooth if you copied everything on the surgery. But you have to know the risk. I was trying to show you one last case, but I think I don't have time. When I manage a case with almost half of the buccal plate missing, and I have a 3 to 4 year combing follow-up. I don't think I have time to show it, maybe in another time, but I can show you, if I may, just the follow-up. Here you see the initial situation, the post-extraction soft tissue and grafting, immediate loading. This is 1 year follow-up. This is the final situation. Okay, this is an implant. This is the implant. This is the crown. And this is a 3-year follow-up. Okay, I don't have x-rays because the patient lives in the United States. And I wanted to have a combing CT to show you my post-op. And this is a challenging case. This is a very difficult case, triangular shape. This is thin biotype, but we manage it. We manage it nicely, but I don't recommend you to do this. This is very difficult, and you have to talk to your patient. You have to know your skills. You have to know your abilities. And if this happens, you can send it to Sheng, and he can make it beautiful and stable. Hey, Sheng, it's good for you, that one? They are going to send all of their difficult cases to you, okay? So be prepared.
Okay, so actually Dr. Srain cannot speak right now. He's still in
Okay.
a mode stage. Okay, let's go to the second question.
Okay,
He
second
would like to
question.
ask for the indication and criteria for choosing the crown materials.
Okay. This is a very good question. I think number one, you will need to know the expectations of your patients. Usually in this day and age, people don't want to have any metals on the aesthetic areas, okay? So usually doing a titanium base or, excuse me, a titanium abutment, it would be difficult. And I've shown you that if you do, I don't use standard abutments. I don't like it. I usually do a provisional and manage the soft tissue and the emergency profile in all of my cases, and 98% of them in the aesthetic area or on the posterior area. And you talk to your lab. Biologically, you can use titanium. Biologically, you can use zirconia. And biologically, you can use lithium disilicate. You have those three materials. The scientific data, it's pro, or is in favor of polished titanium. It's in favor, and my clinical cases that I've been following for a lot of time, the best cases that I've been seeing are the zirconia hybrid abutments with no ceramic and no glaze in contact with the soft tissue, where the lab nicely and gently hand polish it. I think is a very nice way to do it. And you can apply it, ceramic directly to it. You have a very good dental technician, or you can do a lithium press. Do the zirconia abutment and do a cement lithium disilicate. You can do it CAD-CAM, or you can do it press. I prefer, in almost all of my cases, or to do it zirconia with a titanium base, cemented to the titanium base, cemented on the lab, not cemented on the mouth of the patient. If you can do it, most of my crowns, 85% of them are screw retain. Almost all of my crowns in the anterior area today, we have a dynamic screw that you can go in 20 degrees angle and you can screw retain your crown. But if you don't have this kinds of situation, of your implant system don't have this kind of screw, you can do a lithium disilicate crown press, or a zirconia 3-type blocks that you have different translucencies. And if you have a very nice technician and you know how to bond, you have very nice results. So if you have thick 2.5 millimeters to 3 millimeters of soft tissue, you can do whatever you want. You won't have any problems. But if you have thin tissue and the patient don't want to do any soft tissue grafting, I prefer you to go to the zirconia or the lithium disilicate. I prefer a lot to do it zirconia, because zirconia, you have a way to not have the metal from the bottom show up. Sometimes if you do lithium disilicate, you will have a grayish tone value coming from from the tissue, even doing a wide restorations. So I prefer to go the zirconia, or the in a second option, go lithium disilicate. Because the response to the soft tissue, it's been proven that it's much better. Always clean, always nicely done, and hand polished from your dental technician. Okay, no ceramic in contact with the soft tissue, specifically in the subcritical contour. And I think this is the most predictable way that we today have in my hands. Okay.
So
another question.
I have one question about the critical area of your emergent profile design,
Yeah.
for choosing the type base. What the millimeter according to your subcrestal implant placement level? What's the millimeter you choose, or do you have any choosing of your millimeter of your type base according to your depth placement, or according to the subcrestal placement of your implant?
I understand. This is something of that we've been learning on our daily practice. Okay, if you do, this is very important. This is an article from Professor Christian Hammersley, I think, 2001, 2002, I don't remember. And he explained that if you have, and this is important you to know, you have today to know the height and the width of the soft tissue. If you are going to place an implant and you have a 2 millimeter height of soft tissue, remember, Professor Linkuvicius talks a lot of this, and his clinical trials has been showing the things Professor Hammersley has been talking for the past 25 years. Is this: if you have a 2 millimeter height soft tissue, you need to have 3 to 4 millimeters of emergency profile. So you will have suckle, space for the succular, for the long epithelium, and the connection, the soft tissue connection between the implant and the abutment. So if you put your implant, if you have 2 millimeter height, you will put your implant 1 millimeter or 2 millimeters below the bone. In the posterior area, this is a problem. You cannot put an implant 11 millimeters inside the bone. That's a problem, because you have to put a shorter implant. Okay? Usually the same thing in the posterior area with the molars. So you have to manage it. One way of doing it, if you have space, good, you put it 1 to 2 millimeters down, or the same day that you put the implant, you have to do a soft tissue grafting to plump up the soft tissue. So you can have a 3 millimeter soft tissue and you can put it to the level of the bone, or 1 millimeter below. If you have 3 millimeters to 4 millimeters of thickness of soft tissue, you can put your implant at the level of the bone. In the aesthetic area, we always put it 1 to 2 millimeters below the crest of the marginal bone. Why? Because you are going to have a resorption. So the T-base, when you do the final restoration, and I've been showing you on my my post-operative X-rays, you see a little bit of bone resorption. Why? Because we put a very or a low T-base. If you put it 2 millimeters, you will use a 2 millimeter height T-base. So you can manage the bone. So you do not press the bone over there. If you press the bone, if you press the soft tissue, it will remodel. So this is the selection of a tie base. If you use a tie base and you have only 1 millimeter of emergency profile, you cannot use a 2 and 3 millimeters. So this is the important thing. You will have to see much better the thickness and the height of your soft tissue. This will tell you where to put the platform of your implant. We've learned this with time. We've learned this doing mistakes. We learned this having problems because we didn't understand the biology. We have to have a space for the biology width. And one mistake we did is to copy exactly the shape of the tooth. You cannot do this. This is not good. You only have to copy it 1 millimeter below the critical contour. This is the thing that you have to copy exactly from the tooth. From there down, always a big space, a convex space, so you can fill it with soft tissue and you can fill it with bone.
So it is the concept or about the talking about the subcrestal implant. What about the bone level implant placement?
Okay, the bone level, I told you, if you have not enough soft tissue height, or in the third, on the time of the surgery, you do a soft tissue graft, because if you put it at the bone level and your soft tissue, it's not enough, you will have eventually a bone remodeling, and you will have problems. So when you think to put your, if it's hex, if it's external hex, and if it's conical connection, you will have bone resorptions if the height, if you put it at the bone level, conical connection, internal hex or external hex. If you put it at the level of the bone and you have only 2 millimeters of height of soft tissue, you will have bone remodeling because you don't have space for the biologic width. So if you work with a system that, like the Stroman soft tissue level, it's very complicated if you don't have enough soft tissue. If you work with an implant that is to the, you cannot put external hex below the bone because you have micro movements and you have bacterial infiltration. That's why we are changing the biomechanics. I'm not telling you that external hex is not good. I'm not telling you that internal hex is not good. We have many cases, but I think this is the evolution of the systems. You see that almost all of the brands have conical connection. They have platform switching. And this is why, because we are understanding the biology and the literature is over there. And my cases, when I've been following them, I see those situations. So for you that are beginning in the implant dentistry, if you don't want to make the mistakes that I made, you have to study. You have to study biology. You have to study the latest research from people that know what they are doing, because there are a lot of ridiculous papers with no methodology, and that's it. I think the only thing that I can do is study, practice, and manage your skills. I come from a small country. Your country is much bigger than me. And if you have passion and if you have desire to do good dentistry, you can do it. And I've been seeing on Dr. Xuan's cases, he's in the correct path. He has to learn some stuff like everyone. And another thing that I like to talk with you, technology doesn't make you a better dentist. Technology helps you to be a better dentist when you are a good dentist. I don't know if you think the way that I think. The
same thing, the same thinking. Just to relieve the stress of working.
If you don't know biology, if you don't have the skills, you can have a 3Shape, you can have a CAD/CAM, you can have surgical guides. We can speak, if you want, about guided surgery. I am doing now post-extraction implant. I think for you, it's a very nice thing because it will help you plan ahead. It will help you be more precise and more secure on your surgeries. But if you don't know biology, if you don't have the skills, the machine won't give you more brain power or will give you more skills to make your cases. It's good. I think CAD/CAM is good. I think digital dentistry is good. But if you don't know the basics, my friends, you will make the same mistakes in digital dentistry.
All right, doctor, last one question we have. So what is your ideal treatment for the buccal bone defect in immediate implant placement?
Well, I didn't have time, but if you can look up, and I think most of you on your implant programs, I think they've shown you the classification from Professor Nicholas Eliam from NYU that divides or classifies the alveolar process. Let me see if I can show you. Sorry, just to finish up this, and I won't take much time of the next presenter. You see here, this is a very nice article from 2007 that divides the socket in 3 shapes. The first one, or type 1, I have the soft tissue and hard tissue at the normal levels. Type 2, I have the soft tissue at the normal level, but I have bone resorption. And at type 3, I have a vestibular dehiscence and a soft tissue dehiscence. In type 1 and type 2, in my clinic, in my way of thinking, I always do post-extraction and immediate loading. In the type 1, I use bone grafts, slow resorbing, xenograft, specifically BioOS, or excuse me, I do a allograft, 50-50, cortical cancels, and soft tissue grafting. In the type 2, I use bone allograft, I use a membrane, I use the ice cone technique from Professor Tarnow. I push it between the soft tissue here, between the soft tissue and the bone. I first put the soft tissue, then I put the membrane. First, I put the implant, then I put the soft tissue, the membrane, and lastly, I fill up the gap. that was the case that I show you from the guy that came from the States. This is the way I manage type 2 cases. Type 3, I don't do immediate implant placement. I usually let it heal and then see the defect, see the resorption, and then manage it with GBR techniques. Or I use the sausage technique, or I use a Teflon with a reinforced membrane to build up if I have a vertical and a horizontal bone defect. But they're very difficult cases, very difficult to manage. And usually we have a 1.5 to 2 years of treatment plan. Did I respond? Good? No good? Hello? Are you there?
Yeah, I think so. Yes. Thank you so much
Okay.
for not just answering the question, but also very inspiring as well. Very powerful message. Thank you so much. And
Okay.
I guess we have to move on to the next session.
Okay, let me get out. And just a last thing to say. Thank you very much to the Empower Dentistry Society. I'm honored and I'm pleased to speak to you. If you have anything that I can help you, next year maybe we can do something over there. I will be at your orders. Any questions that you didn't like to answer that asked me, just feel free to send me an email. Okay, Henry, thank you very much. Dr. Schwenk, thank you very much for the invitation, and hopefully that I can learn. You can learn a little bit from the things that I have shown you today. Thank you.
Thank you, Dr. Dioracy. Anyway,
okay.
I was wondering if you have time to stay for the discussion session, because after the second lecture, we plan to have a discussion so the speakers can talk to one another.
Okay.
It will be nice if you can join us back later. You may
yes.
take a break first.
Okay, I will take a break, and I would eat something, and then I will see the presentation, and I will stay to the final discussions. Thank you, Henry.
That will be nice. Okay, thank you so much.
Thank you.
Okay, so I would like to introduce you to our next speaker, Dr. Mok Phyrum. He graduated from University of Health Sciences, and after he graduated, he went on several training in many countries, including Japan, Malaysia, Hong Kong, Korea. And in 2016, he received a diploma in orthodontics from Korea. And in 2017, he received the Master of Science of Oral Implantology from Germany. And he is also the president of Dental Implant Society of Cambodia. And today he will be talking about rehabilitation for severely resorbed dentistry. So please welcome him.
សួស្តីស្ដាប់ឮខ្ញុំទាំងអស់គ្នា Hello Henry ស្ដាប់ឮទេ ឮលោកគ្រូឮបាទ Okay good morning Dr. Dioracy, and because my English is not good and most of the participants are local, so I want to speak my local language. Okay. អញ្ចឹងយើងចាប់ផ្ដើមpresentation របស់យើងហើយម៉ោងដូចជារៀងខើចតិចហើយគៀកម៉ោងបាយដែរប៉ុន្តែអត់អីទេព្រោះបានញ៉ាំបាយផឹក ច្រើនហើយអូខេអញ្ចឹងtopic របស់ខ្ញុំគឺយើងនិយាយពីភាសាខ្មែរថាការសាងសង់ឡើងវិញនៅធ្មេញ Identilus ដែលមាន bone resorption ខ្លាំងអញ្ចឹងខ្ញុំនឹងនិយាយពី treatment plan រហូតទៅដល់ prosthetic យើងបានឮspeaker ទី1ហើយគាត់បាន present អំពី immediate implant ជាមួយនឹង reference ជាច្រើន article ជាច្រើនប៉ុន្តែ topic របស់ខ្ញុំនេះដោយសារមានពេលវេលា prepare វាខ្លីដែរអញ្ចឹងខ្ញុំ select យក case ដែលចាស់ហើយដែលគិតថាមានប្រយោជន៍ដល់ participant យើងហើយបើជាreference បើជាមិនសូវមានច្រើនបានជាលក្ខណៈ clinical case ច្រើនប៉ុន្តែបើសិនជាparticipant យើងចង់បាន reference តាក់ទងទៅនឹង point ណាមួយខ្ញុំអាច share បានអូខេខ្ញុំមាន clinic ដ៏ទូចមួយនៅភ្នំពេញយើងដូចអ្នកទាំងអស់គ្នាដឹងស្រាប់ហើយនេះបាទរូបថតនេះគឺថតក្រោយពីចូលធ្វើការមកវិញក្រោយពីឈប់មួយខែ COVID បាទអរគុណ COVID ដែរដែលយើងអាចបានដេកស៊ីមួយខែហើយខ្ញុំក៏មានជា training center មួយដែរនៅជាន់ខាងលើផ្នែក clinic ខ្ញុំហ្នឹងខ្ញុំមាន train basic ហើយនិង advanced course ដែរហើយនេះជាគ្រូពេទ្យរបស់ខ្ញុំដែលជួយការងារខ្ញុំស្ទឹងតែ70ទៅ80% ហើយថ្ងៃនេះខ្ញុំធ្វើតែការងារមួយចំនួនតូចទេភាគច្រើនខ្ញុំធ្វើ surgery implant surgery ហើយ prosthetic គឺពួកគាត់ជាអ្នកជួយធ្វើខ្ញុំហើយ case ដែលខ្ញុំយកមក present ទាំងប្រមាណនៅថ្ងៃនេះក៏បានការជួយភាគច្រើនពីក្រុមពួកគាត់ដែរហើយនេះក៏ជាក្រុមខ្ញុំដែរដែលមានទាំង labo ផងខ្ញុំមាន labo ផ្ទាល់ខ្លួនរបស់ខ្ញុំ in house តែម្ដងមាន machine milling ហើយនិងខាង labo សម្រាប់ធ្វើការងារ ceramic ហើយនេះក៏ជាខ្ញុំចង់រំលឹកតិចដែរនេះជា seminar ទី1របស់ខ្ញុំដែលខ្ញុំនិយាយពី Identilus តើតើនឹង all on 4ហើយក៏ខ្ញុំរីករាយដែរដែលបានថ្ងៃនេះខ្ញុំសង្កេតឃើញparticipant ទាំងអស់នេះសុទ្ធតែជាអ្នកដែលបានចូលរួមក្នុង seminar ទី1នឹងរបស់ខ្ញុំដែរបាទអញ្ចឹងយើងជួបគ្នាមួយសារទៀតជាមួយនឹង content អាចរៀនថ្មីខ្លះហើយមាន content ខ្លះចាស់ដែរអូខេហើយយើងក៏ដឹងស្រាប់ទាំងអស់គ្នាហើយថាយើងទទួលផលប៉ះពាល់ខ្លាំងពី coronavirus ហើយដែលមិនថាប៉ះពាល់តែយើងទេគឺប៉ះពាល់ worldwide ចេះយើងបន់ឲ្យវាឆាប់ផុតទៅទោះបីយើងបានឈប់មួយខែហើយគ្រប់គ្នាប៉ុន្តែយើងក៏អត់ចង់ឈប់តទៀតដែរព្រោះតែឈប់តទៀតប្រហែលជាដាច់បាយហើយដំណឹងល្អសម្រាប់ថ្ងៃនេះគឺសម្រាប់ស្រុកខ្មែរយើងគឺយើងមិនមាន case ថ្មីទេហើយក៏មិនមានអ្នកជាដែរហើយយើងក៏បន់ស្រន់ព្រះអត់មាន case ថ្មីអញ្ចឹងប្រហែលមួយខែទៀតទៅនឹងយើងអាចជោគជ័យលើ coronavirus ហើយអូខេអញ្ចឹងខ្ញុំនឹង present 4 case តាក់ទងទៅនឹង Identilus នេះហើយ case ដែលខ្ញុំ select មកនេះគឺជា case ដែល សម្រាប់ខ្ញុំគិតថាវា complex វាព្រោះថាមាន bone resorption ច្រើនវាមានបាត់ hard tissue and soft tissue អញ្ចឹងយើងត្រូវសាងសង់វាឡើងវិញយ៉ាងម៉េចខ្លះcase ទី1នេះជា case ដែលចាស់របស់ខ្ញុំ case នេះខ្ញុំធ្វើប្រហែលជា 3-4 ឆ្នាំមុន case នេះគាត់មក clinic ខ្ញុំដោយគាត់មានបញ្ហាឈឺទៅលើ removable denture របស់គាត់នេះគាត់ពាក់ removable denture នៅខាងក្រោមហ្នឹង complete denture នៅខាងក្រោមហ្នឹងប៉ុន្តែដោយសារ ridge របស់គាត់ហ្នឹងវា resorb ខ្លាំងពេកហើយវាស្ទឹងស្ដើងដូចមុខកបិតហើយដល់អញ្ចឹងនៅពេលដែលគាត់ដាក់អាហ្នឹងទៅគឺគាត់ឈឺអញ្ចឹងនៅពេលដែលយើងជួបអ្នកជំងឺភាគច្រើន identalus គឺពេលដែលគាត់មកជួបយើងហ្នឹងគឺជាពេលដែលគាត់បានន័យថា bone របស់គាត់ហ្នឹងគឺស្ដើងមែនទែនហើយបើនៅខាងក្រោមវិញគឺភាគច្រើនគឺពេលដែលreach របស់គាត់ហ្នឹងសឹងតែរៀបស្មើទៅដល់ IDN canal ហើយនៅក្នុង case នេះចឹងគឺគាត់ reach របស់គាត់ហ្នឹងគឺ resolve ខ្លាំងមែនទែនអានេះគឺជារូបថតខ្ញុំថតដើម្បីមើលពី profile របស់គាត់ថាតើគាត់ត្រូវការ prototype របស់គាត់នឹងត្រូវការ lip support បន្ថែមឬមួយក៏មិនបាច់ទេអញ្ចឹងជាធម្មតាគ្រប់ case identalus យើងត្រូវតែសិក្សាមើលពី extraoral និង intraoral ព្រោះថាការសម្រេចចិត្តនៃការធ្វើ final prosthesis និងការសម្រេចចិត្តនៃការដាំ implant គឺត្រូវសម្រេចចិត្តពី extraoral ឬក៏ពី prototype ដូចខ្ញុំប្រាប់អញ្ចឹងនេះគឺជា chief complaint របស់គាត់អញ្ចឹងគាត់ denture របស់គាត់ loose ហើយគាត់ឲ្យតែញ៉ាំអីអត់កើតទេព្រោះខាងលើរបស់គាត់គឺជា fixed bridge ហើយនេះជា X-ray panoramic របស់គាត់ជាធម្មតាក្នុង consultation ដំបូង case identalus ខ្ញុំភាគច្រើនគឺយើងថតតែ pano សិនដើម្បីយើងអាចមើលថាតើយើងអាចមាន idea អីខ្លះអញ្ចឹងក្នុង consultation ខ្ញុំភាគច្រើនខ្ញុំឲ្យ option ទៅអ្នកជំងឺ3 option ទី1គឺសម្រាប់អ្នកជំងឺ identalus ខ្ញុំឲ្យទៅលើ implant over denture អាច2ឬក៏4អាស្រ័យទៅលើ available bone ឬមួយក៏finance របស់គាត់អញ្ចឹងយើងអាចធ្វើជារូបភាព animation អញ្ចឹងដើម្បីបញ្យល់គាត់ឲ្យគាត់កាន់តែយល់ថែមទៀតអញ្ចឹងនេះជា option ទី1ហើយខ្ញុំក៏ប្រាប់ពី advantage និង disadvantage ទៅគាត់ដែរអញ្ចឹងដូចដែលយើងដឹងស្រាប់ហើយ advantage របស់ removable គឺការវាកាត់វាទូចហើយវា cost អស់តិចហើយគាត់អាចដោះលាងសម្អាតបានប៉ុន្តែ disadvantage យើងដឹងថាបើយើងធ្វើ removable យូរឆ្នាំទៅអ្នកជំងឺត្រូវការកៅ maintenance គាត់អាចឡោកជ័រដែលនៅខាងផ្នែក female part ហ្នឹងហើយនៅពេលដែលគាត់ remove ឡើងហ្នឹងគាត់បាត់ keratinized tissue នៅខាងក្រោមហ្នឹងអញ្ចឹងក្រោយពីរយៈពេល4ទៅ5ឆ្នាំក្រោយមកខ្ញុំមាន case ដែលយើងធ្វើ 4-5 ឆ្នាំក្រោយមកគឺគាត់បើផ្នែកខាងក្រោមវិញភាគច្រើនគាត់បាត់ keratinized tissue អញ្ចឹងយើងត្រូវធ្វើ tissue graft ឬធ្វើអីឡើងវិញព្រោះនៅពេលដែលគាត់បាត់អាហ្នឹងគឺគាត់ដាក់ថ្មីទៅគឺគាត់ឈឺហើយអញ្ចឹងយើងអាចបញ្យល់គាត់ត្រួសពី advantage និង disadvantage នៃ option មួយក្រោយពីបញ្យល់គាត់ទៅគាត់ក៏អត់ អត់ចង់ធ្វើអាហ្នឹងដែរហើយបើយើងគិតពីអាយុរបស់គាត់គឺគាត់តែអាយុ40ជាងណាដូច្នេះគាត់អត់ចង់ប្រើអាហ្នឹងទេអញ្ចឹងគាត់ចង់បានថ្មិញជាប់ថ្មិញជាប់ហើយគាត់រកដែលតម្លៃសមរម្យទៀតអញ្ចឹងយើងគិតថាតើ implant ប្រហែលគ្រាប់ដែលយើងអាចដាក់បានហើយដាក់ថ្មិញជាប់ឲ្យគាត់ហើយដែលយើងជួយសំចៃសម្រាប់អ្នកជំងឺអញ្ចឹងនេះជាអ្វីដែលគាត់ចង់បានគឺ fixed bridge ហើយនឹង affordable ហើយ option ទី2គឺខ្ញុំប្រាប់គាត់ពីការដាំ implant 4គ្រាប់ហើយយើងធ្វើជា fixed bridge ឬយើងហៅថា all on 4ហើយប្រភេទ prosthesis គឺជាប្រភេទ hybrid prosthesis បានន័យថាជាប្រភេទ prosthesis ដែលមានត្រូវការនៅហ្គាំហើយមួយទៀតយើងអាចធ្វើ fixed bridge ដែរប៉ុន្តែយើងដាំ implant នៅផ្នែកបូនខាងមុខហ្នឹងផ្នែកinterforamen ហ្នឹងតែយើងដាំត្រង់តែបើយើងដាំត្រង់ AP spread របស់យើងគឺវាអត់គ្រប់គ្រាន់សម្រាប់យើងដាក់ crown ទៅដល់ធ្មេញ molar ឯងអញ្ចឹងយើងត្រូវការដាំ implant នៅខាងក្រោយ2ទៀតដើម្បីយើងអាចធ្វើ bridge ទៅដល់ molar អាហ្នឹងគេហៅ increase AP spread ប៉ុន្តែយើងមើល case ហ្នឹងឬក៏ case ភាគច្រើននៅផ្នែកខាងក្រោយហ្នឹងគឺ bone វាអត់សូវមានទេអញ្ចឹងភាគច្រើនគឺបើយើងចង់ធ្វើករណីយ៉ាងអញ្ចឹងយើងត្រូវប្រើ short implant ហើយ most of the time គឺ short implant ហើយត្រូវ add ថែម bone graft vertical ឬក៏ horizontal ថែមតិចតួចទៀតអញ្ចឹង short implant មាន6 mm ឬក៏4 mm ហើយបានយើងអាចធ្វើ bridge ហ្នឹងមកអានេះជា option ទី3ប៉ុន្តែបើយើងក៏លេខមើល option នេះគឺយើងត្រូវចាយលុយច្រើនទៅ implant តែ2គ្រាប់ហើយធ្វើ bone graft ហើយក្រោយពី bone graft អីហើយមកបើជាអ្នកជំងឺគាត់អាចត្រូវចាំដល់4ខែទៅ6ខែបានអាចដាក់បដាសនឬក៏អាចយើងធ្វើថ្មិញឲ្យបានដូច្នេះ option នេះជា option មួយដែលខ្ញុំក៏អត់សូវ recommend ទៅអ្នកជំងឺភាគច្រើនដែរបើសិនជាអាចហើយអ្នកជំងឺក៏ក្រោយពីគាត់ពិភាក្សាមកគាត់ក៏សម្រេចយក option ទី2គឺដាំ implant 4គ្រាប់ដោយ2 implant ខាងផ្នែក distal ហ្នឹងយើងធាលវាដើម្បីយើង increase AP spread ឬយើងហៅ technique នេះថា all on 4 treatment concept បានយើងក្រោយពី patient គាត់ okay គាត់អីហើយខ្ញុំទៅធ្វើ3D scan មួយទៀតនៅក្នុង 3D scan នេះគឺមុននឹងធ្វើយើងត្រូវធ្វើ copy denture របស់គាត់ដែលមានស្រាប់ហ្នឹងពីអាចជា composite ឬក៏អាចជា material អីដែលវាអាច radio opacity យើងឃើញradio opacity នេះគឺវានៅឡើង crown នេះយើងអាចដឹងយើងអាច guide ដឹងថាតើdistal implant របស់យើងហ្នឹងនៅពេលដែលយើងដាំធាលអញ្ចឹងយើងដាំវា trade ហ្នឹងតើវាអាចទៅដល់បានថ្មិញលេខប៉ុន្មានខ្ញុំឧទាហរណ៍ថាដូចក្នុង case នេះថ្មិញលេខ35នេះអញ្ចឹងយើងអាចមើលទៅកន្លែងនេះថាតើបើយើងធាលដល់ប៉ុណ្ណឹងតើ position របស់ implant យើងប្រៀបធៀបជាមួយ crown ហ្នឹងវាមាន relation វាយ៉ាងម៉េចខ្លះដូច្នេះយើងមាន idea ច្រើនក្នុងការដែលយើងធ្វើ treatment plan បើយើងឲ្យអ្នកជំងឺទៅថតដោយអត់មានពាក់អីសោះឬក៏ពាក់ denture គាត់ស្រាប់ដែលវាអត់សូវមាន radio opacity ពេលយើងធ្វើ treatment plan សម្រាប់ identified patient យើងអាច plan បាននៅក្នុង software នៅក្នុង X-ray របស់យើងប៉ុន្តែដល់ពេលយើងយក plan យើងនឹងយកមក apply នៅពេលយើងវះកាត់យើងអត់ដឹង guide យើងអត់មាន guide សម្រាប់យើងដឹងថាទីតាំងណាដែលយើងវាស់ទីតាំងណាដែលគួរតែកាត់ឆ្អឹង position implant ហ្នឹងវាយ៉ាងម៉េចអញ្ចឹងអ្វីដែលខ្ញុំ recommend ហើយសម្រាប់ participant ផ្សេងៗទៀតដែរបើចង់ពិភាក្សា case ជាមួយខ្ញុំទាក់ទង Identilus មុននឹងថតត្រូវតែប្រើ denture copy denture ពី radio opaque material ណាបានយើងអាចនិយាយគ្នាបានអូខេយើងបើមើល surgery យើងឃើញនេះជា reach របស់គាត់យើងឃើញបើយើងមើលពីលើទៅយើងគិតថាមើលឃើញ soft tissue ហ្នឹងគឺវាស្ដើងដូចមុខកបិតចឹងហើយបើយើងបើក flap នេះទៅគឺយើងឃើញ reach របស់គាត់គឺស្ដើងមែនទែនហើយត្រូវចាំថា surgery សម្រាប់ Identilus ជួនកាលវាងាយស្រួលប៉ុន្តែបើសិនជាយើងភ្លាត់ស្នៀតយើងអត់បាន follow guideline វាត្រឹមត្រូវទេយើងធ្វើឲ្យ perforate ខាង floor of the mouth អានឹងវាមាន serious complication អាចធ្វើឲ្យមាន bleeding ខ្លាំងអាចរហូតធ្វើដល់អាចធ្វើឲ្យស្លាប់យើងមើលផ្នែក lingual flap នេះយើងឃើញសរសៃឈាមច្រើនណាស់ហើយកន្លែងហ្នឹងបើយើងប៉ះពាល់វាឬក៏យើងធ្វើឲ្យធ្លុះអានឹងវាមានDioracy ខ្លាំងណាស់អញ្ចឹងជា recommendation នៅខាង lingual flap នេះយើងត្រូវបើក full thickness flap ដើម្បីយើងអាចមើលពីមើលនឹងភ្នែកជាក់ស្ដែងពី anatomy របស់ bone ហើយដើម្បីយើងអាចប្រើ periosteal elevator ហ្នឹងដើម្បី protect flap lingual flap ឲ្យយើងអូខេអញ្ចឹងដើម្បីឲ្យបានspace សម្រាប់prote យើងត្រូវការ reusable ខ្លះហើយនឹងកាលណាយើង reusable ហ្នឹងយើងបាន width របស់ bone ហ្នឹងកាន់តែធំសម្រាប់ដាំ implant ដែរហើយនេះជាក្រោយពីដាំ implant 4ហើយភ្លាមដោយពីខាងdistal ហ្នឹងយើងធាលដើម្បីកិច្ច mental foramen ហើយដើម្បីយើងបាន platform របស់ implant ហ្នឹងខិតទៅខាងក្រោយដល់ពេលដែលវាកាន់តែខិតទៅក្រោយយើងកាន់តែមាន AP space កាន់តែល្អកាលណា AP space កាន់តែល្អយើងកាត់បន្ថយ cantilever ហើយកាលណាកាត់បន្ថយ length របស់ cantilever យើង reduce complication fracture ឬក៏ bone resorption ផ្សេងហើយជាធម្មតាក្នុង case ដែល all on 4អញ្ចឹងគឺខ្ញុំបើ mandible ពីច្រើនគឺខ្ញុំ fix multi unit abutment ភ្លាមដើម្បីយើងធ្វើបដោះសន្នឲ្យគាត់ពាក់ភ្លាមហើយអានេះគឺ30 degree angle ដើម្បីយើងកែ angulation វាឲ្យស្របគ្នាជាមួយនឹង0 degree ខាងមុខនេះបើយើងអាចដាក់ immediate temporary បានអូខេហើយ technique ក្នុងការធ្វើ temporary នេះអានេះវា detail តិចប៉ុន្តែវាដូចទាំងការធ្វើ temporary នៅក្នុងថ្មិញបដោះសន្នមកគ្រាប់ដែរនេះខ្ញុំដាក់បដោះសន្នភ្លាមហើយខ្ញុំខំពុំយកទៅធ្វើបដោះសន្នខាងក្រៅហើយគេនេះជា X-ray panoramic X-ray ដែលយើងថតភ្លាមក្រោយពីយើងដាំ implant ហើយដាក់បដោះសន្នឲ្យគាត់ហើយនេះក្រោយពី3 ខែក្រោយមក12សប្តាហ៍ភាគច្រើនគឺ mandible យើងអាចបើសិនជា prime visibility យើងល្អក្នុងរយៈពេល3 ខែហ្នឹងយើងអាចខំពុំបានហើយ Chẳng dương impression dươngប្រើ impression coping សម្រាប់ multi unit apartment ហើយpattern resin នេះយើងខាត់វា section មកដើម្បីយើងកាត់បន្ថយstress វាកុំឲ្យវាទាញអញ្ចឹងយើងកាត់វាជាបំណែកហើយបានយើងផ្សារជាមួយនឹង pattern resin នេះមួយសារទៀតអូខេហើយយើង send ការងារនេះទៅ labo ក្នុងការ send ការងារទៅ labo នេះដោយសារ case នេះយើងធ្វើ CAD CAM ហើយខ្ញុំ send ការងារនេះទៅវៀតណាមអញ្ចឹងយើងត្រូវមានព័ត៌មានគ្រប់គ្រាន់ដើម្បីឲ្យខាង labo នោះ labo ដែលនៅឆ្ងាយហ្នឹងគេដឹងថាកុងតួរបស់យើងកុងតួរបស់ bridge ហ្នឹងចាញទៅប៉ុន្មានប្រវែងថ្មិញទៅប៉ុន្មានអញ្ចឹងយើងត្រូវ copy denture របស់គាត់ដែលវាត្រូវហ្នឹងស្រីឲ្យស្អាតឲ្យហើយ copy ជា stone មកហើយ send ទៅឲ្យ labo ណាតើតែ labo គេមានព័ត៌មាននឹងអស់ហើយបានគេយកទៅគេ scan ពីបដោះសន្នរបស់យើងហើយគេ design តាមហ្នឹងគេ merge គេហៅ merge ក្នុងភាសា CAD CAM គេ merge បដោះសន្នហ្នឹងចូលទៅក្នុងហ្នឹងគេដឹងថា position របស់ denture របស់យើងវាមានប្រវែងប៉ុន្មានចាញទៅដាក់កម្រាស់ប៉ុន្មានហើយត្រូវ cut back ប៉ុន្មានអូខេបាទនេះក្រោយពីមានគេ design មកគេ send មកឲ្យយើងហើយឥឡូវយើង digital ចឹងយើងស្រួលចឹងគេ send មកតាមទូរស័ព្ទឲ្យយើងអាចប្រាប់គេចង់កែអីខ្លះយើងចង់ដាក់យ៉ាងម៉េចក្រោយណាកាត់នេះ midline យ៉ាងម៉េចយើងអាចគូហើយយើង forward ឲ្យគេវិញនៅពេលដែលយើងអូខេហើយបានគេកាត់ចេញជាtitanium នេះជា titanium framework ដែលគេកាត់ធ្វើជា abutment អាចដាច់នេះដើម្បីយើងអាចធ្វើ bridge ground ឬក៏ bridge នៅស្រុកខ្មែរនេះបានអញ្ចឹងការងារដែលខ្ញុំ send ឲ្យគេធ្វើហ្នឹងគឺខ្ញុំ send តែឲ្យគេធ្វើតែ titanium ទេចំណែកការងារផ្នែក gambill up ហើយនឹងយើងអាចធ្វើនៅ labo នៅយើងបានដូច្នេះក្នុងគេនេះជំនាន់ហ្នឹងខ្ញុំធ្វើ PFM តែយើងអាចធ្វើជា zirconia ឬក៏ធ្វើជាអីដែលវា aesthetic ជាងហ្នឹងកន្លែងណាដែល apartment ថ្មីខ្ញុំក៏កន្លែងណាដែល apartment ខ្លីៗខ្ញុំធ្វើជា bridge កន្លែងណាដែល apartment ដាច់ខ្ញុំធ្វើជា ground អូខេនេះជាក្រោយពីយើងដាក់ bridge នឹងរួចមកហើយ patient គាត់ happy ព្រោះតាំងពីចាប់ផ្ដើម surgery រហូតមកដល់ final ហ្នឹងគឺគាត់មានបដោះសន្នប្រើរហូតអញ្ចឹងគាត់ happy នឹង result ហើយ case នេះខ្ញុំបាន follow up បានបែរជា3ឆ្នាំកន្លះដែរ3ឆ្នាំកន្លះហ្នឹងបើគិតមកដល់ឥឡូវវាអាចចូល4ឆ្នាំកន្លះពួកគាត់ខានមក follow up មួយឆ្នាំជាងហើយអញ្ចឹងខ្ញុំឃើញ bone ហ្នឹងវា stable បានល្អប៉ុន្តែ case នេះ cantilever រៀងវែងបន្តិចតែខ្ញុំ reuse occlusal table ដែលផ្នែក molar ហ្នឹង reuse ឲ្យទូចអត់សូវឲ្យធំទេអញ្ចឹងដើម្បីយើងចង់មើលbone ហ្នឹងយើងអាចថត peri apical បន្ថែមទៀតទៅយើងចង់មើល bone level ហ្នឹងអូខេអញ្ចឹង patient គាត់ happy ហើយយើងក៏ចំពោះ case នេះយើងអាច call គាត់មួយឆ្នាំម្ដងមក follow up មក check មើលហើយមក unscrew ចេញដើម្បីយើងអាចដោះលាង សម្អាតនៅខាងក្រោម bridge នឹងបានយើងចូល case ទី2 case នេះដោយសារខ្ញុំមាន consent ពីអ្នកជំងឺដែរអញ្ចឹងខ្ញុំអត់ចាំបាច់បិទភ្នែកគាត់ទេប៉ុន្តែក៏ខ្ញុំสนมពរគ្នាយើងដែលជា participant កុំ share អី content នឹងទៅក្នុង Facebook ដែរអូខេគេនេះអ្នកជំងឺនេះគាត់មកជួបខ្ញុំដំបូងហ្នឹងគាត់មាន denture របស់គាត់ដែរប៉ុន្តែគាត់ភ្លេចយកមកគាត់ថា denture របស់គាត់ហ្នឹងគាត់អត់សឹងតែអត់ដែរប្រើអញ្ចឹងគាត់ទុកនៅផ្ទះហើយគាត់មកជួបខ្ញុំតែអញ្ចឹងហើយតាម history របស់គាត់ហ្នឹងគឺគាត់ប្រើ denture របស់គាត់ដែលលងហ្នឹងដែលអត់កើតហ្នឹងប្រហែលជាជិត10ឆ្នាំហើយគាត់ថាគាត់ពាក់តែពេលចេញទៅជួបភ្ញៀវឬក៏ទៅញ៉ាំកាយទេប៉ុន្តែការហូបចុកគឺគាត់ប្រើតែថ្មិញដែលនៅសេសសល់ប៉ុណ្្នឹងទេយើងឃើញ occlusion របស់គាត់ឯcanine ខាងក្រោមនោះខំទៅរឹសថ្មិញខាងលើអញ្ចឹងគាត់ពិបាកញ៉ាំមែនទេគឺគាត់ញ៉ាំបានតែប៉ុណ្្នឹងទេប៉ុន្តែអ្វីដែលយើងឃើញជា positive គឺ reach ខាងលើហ្នឹងនៅពេលដែលមានរឹសថ្មិញនៅអញ្ចឹងហើយ occlusion ខំទៅទៀតគឺថាវាមាន internal loading កាលណា internal loading ហ្នឹងវាជួយ preserve bone អញ្ចឹង reach ខាងលើហ្នឹងគឺនៅល្អស្អាតល្អតែ reach ខាងក្រោមគឺវា resolve ខ្លាំងមែនដែរនេះជា X-ray របស់គាត់បូននៅខាងលើហ្នឹងវាមានដែរប៉ុន្តែវាតិចតួចចំណែកបូននៅខាងក្រោមហ្នឹងគឺ resorption ខ្លាំងមែនតើដើម្បីធ្វើ treatment plan សម្រាប់ edentulous patient យើងត្រូវការដឹង parameter មួយចំនួនជាពិសេសធ្មេញខាងលើកាលណាយើង plan អត់បានល្អ final prosthetic របស់យើងប្រហែលជាអាច fail ទាំង aesthetic ហើយកាលណា fail លក្ខណៈ edentulous អញ្ចឹងយើងពិបាកកែអញ្ចឹងខ្ញុំលើកយក parameter ខ្លះដែល Dr. Jivraj គាត់ចុះនៅក្នុងសិភៅរបស់គាត់មាន 7 parameter ទី1មុននឹងយើង plan ថា implant យើងគួរដាំយ៉ាងម៉េចចំនួន implant យើងប៉ុន្មានយើងទៅ plan ពី pro តែហើយអ្វីដែល plan ពី pro តែដំបូងគេគឺយើងត្រូវដឹងថា incisal edge របស់ maxilla ហ្នឹងនៅកន្លែងណា incisal edge របស់mandible ហ្នឹងវានៅកន្លែងណាហើយការសិក្សានេះដែលដឹងនៅកន្លែងណាយើងអាចប្រើ denture ចាស់របស់គាត់បើសិនជាវា acceptable ឬក៏យើង mock up ថ្មីយើងធ្វើថ្មីឬក៏យើងអាចថតហើយយើងធ្វើ digital planning smile digital smile design អញ្ចឹងដើម្បីយើងដឹង position របស់ incisal edge ហើយយើងត្រូវដឹងពី restorative space ព្រោះកាលណាយើង plan ពី final restoration របស់យើង metal ceramic យើងត្រូវការកម្រាស់តែប្រហែលជា10ទៅ12មីលីម៉ែត្រទេបើយើងធ្វើ PFM ធម្មតាប៉ុន្តែបើយើងធ្វើដូចជាពួក hybrid prosthesis ឬក៏ screw retain ដែលមាន gam support យើងត្រូវការយ៉ាងហោចក៏ពី15មីលីម៉ែត្រឡើងទៅដែរ restorative space ដែលយើងចង់និយាយនេះគឺគិតពី incisal edge របស់incisor ហ្នឹងទៅដល់ level របស់ bone អញ្ចឹងបើយើងអត់បាន plan អានឹងមុនទេនៅពេលដែលយើងវះកាត់យើងអត់ដឹងថាត្រូវ reuse bone ឬអត់ reuse bone ប៉ុន្មានហើយយើងត្រូវដឹងពី lip support ថាតើ case របស់យើងហ្នឹងបើសិនជាយើងគ្រាន់តែ បញ្ចេញ crown ឬក៏អីហ្នឹងតើវាអាចជួយ support lip បានអត់យើងត្រូវដឹងពី smile line lip line ហើយបើសិនជាយើង reuse bone យើងត្រូវធ្វើ contour emergent profile emergent ហ្នឹងយ៉ាងម៉េចដើម្បីឲ្យអាច cleansable អីផ្សេងហើយនឹងចុងក្រោយគឺ occlusion ប៉ុន្តែដើម្បីកុំឲ្យស្មុគស្មាញច្រើនខ្ញុំចង់ឲ្យពួកយើង follow ទៅ guideline 2នេះដែលសម្រាប់ case ដែល simple គឺអានេះខ្ញុំយកតាម Dr. Dioracy ណាដែលគាត់ចុះក្នុងសៀវភៅ Dental Treatment Planning តាមឆ្នាំ 2008 ហ្នឹង factor 2 ដែលយើងត្រូវសម្រេចចិត្តមុននឹងយើងវះកាត់ឬក៏យើងធ្វើ final restoration របស់យើងហ្នឹងគឺយើងត្រូវដឹងពី types of defect ថាតើឆ្អឹងការបាត់បង់ឆ្អឹងឬការបាត់បង់ soft tissue ហ្នឹងវាជាប្រភេទអីហើយនឹងមួយទៀតគឺមើល X-ray ពីរហ្នឹងយើងអាចយកមកសម្រាប់ចិត្តបានអាចធ្វើ treatment plan បានដែលជា 70-80% នៃ case ទាំងអស់ហើយខ្ញុំក៏ភាគច្រើនខ្ញុំយកទៅពីរហ្នឹងជា guideline របស់ខ្ញុំដែរអីគេជា types of defect អញ្ចឹងយើងអាចឃើញអ្នកជំងឺ edentulous ចូលមក clinic យើងអាចមើលទៅឃើញរីកអញ្ចឹងដូចគ្នាប៉ុន្តែយើងឃើញរីកអញ្ចឹងជួនកាលគាត់បាត់តែធ្មេញទេបានន័យថាយើងដាក់តែធ្មេញឲ្យគាត់វាអូខេហើយមានពេលខ្លះទៀតយើងឃើញអ្នកជំងឺមក edentulous អញ្ចឹងប៉ុន្តែយើងត្រូវការដាក់តែធ្មេញទៅទេអត់អាចជួយ support lip អត់អាចឲ្យមាន aesthetic បានទេយើងត្រូវការ gum ទៀតអញ្ចឹងDr. Dioracy ហ្នឹងគាត់ចែក defect ជាពីរអញ្ចឹងយើងឆែកមើលតែពីរហ្នឹងដំបូងសិនថាតើអ្នកជំងឺដែល edentulous ឬក៏ដែលក្រង edentulous ហ្នឹងតើគាត់បាត់បង់អីគេគាត់អាចបាត់បង់តែធ្មេញឬក៏ហៅ teeth only defect ឬក៏គាត់អាចបាត់ទាំងធ្មេញហើយបាត់ទាំង soft tissue បាត់ទាំង gum ឬក៏ហៅ composite defect អានេះមានគេខ្លះ edentulous ចឹងមែនប៉ុន្តែយើងគ្រាន់តែដាក់ធ្មេញទៅតាម implant តាម4គ្រាប់ឬ6គ្រាប់ហើយយើងដាក់ធ្មេញទៅគឺវាអូខេប៉ុន្តែអ្នកជំងឺខ្លះយើងដាក់តែធ្មេញទេវាអត់ aesthetic ទេព្រោះជួនកាលrich របស់គាត់ហ្នឹងវា resorption ខ្លាំងពេកអញ្ចឹងយើងត្រូវការដាក់ថែមទាំង gum ថែមទាំងអីទៀតកាលណាថែមទាំង gum វាតាក់ទងទៅដល់ប្រភេទនៃ protein អញ្ចឹងវាធ្វើការសម្រេចចិត្តរបស់យើងនឹងតាក់ទងទៅដល់ protein ទៀតកាលណាយើងថែម gum ត្រូវតែ screw retain 100% ទៅ screw retain ហើយ position implant ហ្នឹងត្រូវតែយ៉ាងម៉េចខ្លះកាលណា gum អូខេហើយកាលណា missing teeth យើងអាចធ្វើ cement retain ឬក៏ screw retain យើងអាចធ្វើ separate bridge ប៉ុន្តែ position implant ហ្នឹងត្រូវតែចំធ្មេញមួយបើសិនយើងធ្វើ cement retain អញ្ចឹងហើយកាលណាយើងដឹងពីប្រភេទ defect ហ្នឹងយើងអាច plan implant ហ្នឹងបានល្អ implant placement បានល្អដូច្នេះសម្រាប់ edentulous patient គឺយើង plan ពី protein ទៅ surgery ដូច case នេះចឹង case នេះខ្ញុំដាំ implant ឲ្យគាត់7គ្រាប់ហើយយើងដាំ implant ទៅតាម position ដែលយើងបាន plan ថ្មិញលេខ11ឲ្យចំលេខ11 21ចំលេខ21ហើយ23ចឹងចំលេខ23ប៉ុន្តែបើសម្រាប់អ្នកជំងឺដែលមាន composite effect ដែលគាត់ត្រូវការ gum ដើម្បី support ចេះយើងអាចដាំ implant កន្លែងណាក៏បានដែល available bone ដែលមាន bone គ្រប់គ្រាន់ហើយដែលបង្កើតជា position implant ហ្នឹងបង្កើតជា AP spread បានគ្រប់គ្រាន់អញ្ចឹងយើងត្រូវរកអាហ្នឹងឲ្យឃើញចំណុចសំខាន់ទី1 ខ្ញុំលើកឧទាហរណ៍មួយខ្ញុំលើកឧទាហរណ៍ដូចតែគេនេះpatient គាត់មកជួបខ្ញុំអញ្ចឹង identity អញ្ចឹងសល់ឬថ្មិញតិចតួចអញ្ចឹងសំទោសសំសាទៀតគាត់សល់ឬថ្មិញតិចតួចអញ្ចឹងហើយខ្ញុំឲ្យគាត់ញឹមឲ្យថតមើលនៅពេលដែលយើងថតមើលយើងឃើញមានហ្គាំគាត់យើងឃើញមានរិចខ្លះហើយគាត់មានស្មាយមានរិចខ្លះហើយតែចាំថានៅពេលដែលគាត់ថតនៅពេលដែលយើងថតអ្នកជំងឺមើលហើយយើងឃើញរិចខ្លះអញ្ចឹងភាគច្រើនគឺគាត់បាត់តែថ្មិញទេគាត់អត់មានបាត់ហ្គាំទេហើយនេះខ្ញុំជា simulation ខ្ញុំចង់ធ្វើ design មើលបើសិនជាយើងថែមហ្គាំគាត់ទៅជាយ៉ាងម៉េចវិញអញ្ចឹងបើសិនជាយើងថែមហ្គាំបានន័យថាគាត់ទៅជាយើងក្រោយពីដាំ implant ហើយយើងដាក់ថ្មិញឲ្យគេពីគេធម្មតាយើងកែគេទៅ gummy smile បាត់ហើយវា aesthetic fail បាត់ហើយអញ្ចឹងយើងអត់ត្រូវការ gum ទេគាត់ត្រូវការតែគាត់បាត់បង់ថ្មិញទេអញ្ចឹងយើងដាំ implant ហើយយើងដាក់តែថ្មិញឲ្យគាត់ទេបើគាត់បាត់បង់តែថ្មិញ position របស់ implant របស់យើងនៅពេលដាំនោះត្រូវតែប្រយ័ត្នប្រយែងគឺដាំឲ្យចំទីតាំងថ្មិញមួយមិនដាំទៅតាមបូនដែលមានទេកន្លែងណាដែលខ្វះបូនយើងថែម graft ថែមអីតាមហ្នឹងហើយនេះគឺជា mock up របស់ដុកទ័រវិទូដែលគាត់ធ្វើការងារហ្នឹងអញ្ចឹងនៅពេលដែលយើងដាក់តាយើងសាក់លោតែresin ហ្នឹងមកយើងឃើញគាត់ aesthetic acceptable អញ្ចឹង patient នេះគឺ teeth only defect យើងមើល patient នេះវិញគាត់មក identiless ហើយបើយើងឲ្យគាត់ smile មើលគឺគាត់យើងមើលអត់ឃើញ ridge របស់គាត់ទេប៉ុន្តែបើយើងមើលអត់ឃើញ ridge ហ្នឹងមិនមែនបានន័យថាគាត់មាន composite defect ទេគាត់បាត់ gum ទេគាត់អាចបាត់ teeth only defect ឬក៏ composite defect អញ្ចឹងយើងថតពីចំហៀងមើលទៀតយើងឃើញprofile របស់គាត់យើងឃើញមុខរបស់គាត់គឺបើសិនជាយើងអត់ប្រើ gum ជំនួយទេគឺយើងអត់អាចលើក profile របស់គាត់ឲ្យមកស្អាតបានទេអញ្ចឹងនេះជារូបភាពដែលក្រោយពីខ្ញុំដាំ implant ហើយដាក់ protein គាត់ប៉ុន្តែ case នេះយើង plan តាំងពីមុន plan ថាគាត់គឺ composite defect យើងឃើញ profile របស់គាត់ improve ហើយមានកម្មមានអីតាមទៅហើយយើងឃើញគាត់ happy ហ្នឹងហើយ protein ដែលខ្ញុំធ្វើឲ្យគាត់ហ្នឹងគឺប្រភេទ hybrid prosthesis គឺ screw retain resin acrylic អញ្ចឹងយើងត្រូវការ gum នេះដើម្បីជួយ support lip support របស់គាត់អូខេអញ្ចឹងប្រភេទហ្នឹងគឺគេហៅ composite effect អញ្ចឹងយើងត្រូវសិក្សាមើលអាហ្នឹងឲ្យហើយកាលណាយើងអត់សិក្សាមើលអាហ្នឹងឲ្យហើយយើងអាច reduce bone stir យើងអាចជួនកាល technician គាត់ធ្វើអត់ចេញព្រោះមិនដឹងថាត្រូវថែម gum ឬក៏មិនត្រូវដាក់ gum case នេះវិញcase នេះជា case យូររបស់ខ្ញុំដែរហើយគាត់បើយើងមើលមក plate ទៅគាត់ដូចជា mix រវាង teeth defect ហើយនិង composite defect ប៉ុន្តែបើយើងមាន case អញ្ចឹងហើយយើងមើល soft tissue ឬក៏ bone របស់គាត់ទៅវា compromise មែនទែនដើម្បីឲ្យងាយស្រួលធ្វើ protein ហើយដើម្បីឲ្យការដាំ implant យើងនេះអាហ្នឹងយើងកែវាឲ្យទៅជា composite effect តែម្ដងការកែទៅជា composite effect គឺយើងកាត់bone បន្ថែមអញ្ចឹងគេនេះយើងធ្វើយើងកាត់ bone យើងធ្វើ all on 4ខាងលើហើយនិងខាងក្រោមដុកទ័រខ្ញុំគាត់ធ្វើ all on 5ហើយនិងខាងលើហ្នឹងយើងធ្វើ screw retain pick ដាក់ imax អញ្ចឹងអានេះគឺ mix គ្នារវាង teeth only defect នៅផ្នែកខាងក្រោមហើយនឹង composite defect នៅផ្នែកខាងលើដូច្នេះកត្តាទី1ហ្នឹងគឺយើងត្រូវមើល defect ហ្នឹងថាតើវាប្រភេទ defect អី teeth only defect ឬក៏ composite defect ហើយកត្តាទី2ដែលត្រូវមើលដែរដែលយើងភាគច្រើនយើងដឹងទាំងអស់គ្នាគឺយើងត្រូវ evaluate ទៅលើ X-ray អានេះខ្ញុំដកស្រង់ចេញពី Dr. Dioracy ដែរគាត់បែងចែកថា X-ray ដែលយើងថតហ្នឹងយើងបែងចែកជា3 zone យើងមើល available bone យើងមើល zone ទី1pre-maxilla ហ្នឹង zone ទី1 pre-maxilla ហ្នឹងគឺចន្លោះថ្មិញលេខ13ដល់លេខ23តើវាមានដែរអត់ available អត់ហើយយើងមើល zone ទី2គេគិត zone ទី2ហ្នឹងគិតនំថ្មិញ premolar ហើយនៅ zone ទី3គឺថ្មិញmolar នៅពេលដែលយើងមើលឃើញថា available bone នឹងមានហើយវាមាន treatment option វាផ្សេងណាយើងមើលឧទាហរណ៍ថាបើ case edentulous ហ្នឹងវាមាន zone 1 zone 2 zone 3បានន័យថាពីមុខដល់ក្រោយគឺមានទាំងអស់ហើយយើងអត់ចាំបាច់ដាំ implant ធាលអីទេយើងដាំ implant វាទេយើងដាំឲ្យត្រង់មកយើងអាចធ្វើ prototype ធ្វើអីបានដូចគ្នាហើយបើសិនមានពេលខ្លះហើយយើងជួបភាគច្រើនដែរគឺភាគច្រើនអ្នកជំងឺដែលមានតែ zone 1 ហើយ zone 2បានន័យថា available bone យើងមានតែ premolar ហើយអញ្ចឹងដើម្បីឲ្យក implant យើងអាចដាក់ថ្មិញដល់ molar យើងត្រូវធាល implant យើងត្រូវកាច់ implant ហ្នឹងទៅក្រោយបន្តិចដល់យើងដាំកិច្ច sinus ហើយក៏មាន case ខ្លះគឺមានតែ zone 1 only ហើយក្នុងថ្ងៃនេះខ្ញុំនឹងលើក case ដែលតាក់ទងតែមានតែ zone 1 only កាលហ្នឹងក្នុង recommendation របស់គាត់ឲ្យzygomatic implant ប៉ុន្តែ zygomatic implant វាជា advanced procedure ខ្ញុំក៏អត់ចេះដែរហើយខ្ញុំក៏គិតថាការងារហ្នឹងប្រហែលជាយើងត្រូវការមន្ទីរពេទ្យដែលមាន general anesthesia អីមិនយើងអាចធ្វើកើតអញ្ចឹងខ្ញុំអត់ធ្វើដែរខ្ញុំក៏អត់មានកម្រងនឹងរៀនធ្វើវាដែរដោយសារខ្ញុំអាចធ្វើអីផ្សេងដែលបានល្អជាងហ្នឹងហើយ safe ជាងហ្នឹងអូខេអញ្ចឹងយើង back មក case របស់យើងវិញ case របស់យើងនេះបើយើង analyze មែនតើទៅយើងមើល profile របស់គាត់អានេះខ្ញុំថតដោយអត់ថ្មិញយើងមើលពេលដែលគាត់ញឹមយើងមើលអត់ឃើញ rich ទេប៉ុន្តែយើងមើលអត់ឃើញ rich ហ្នឹងយើងគិតថាគាត់ប្រហែល composite defect ហ្នឹងគាត់ប្រហែលជាបាត់កម្មតែបើយើងមើល profile របស់គាត់មកពីចំហៀងចា lateral profile នេះយើងឃើញគាត់ទោះបីជាអត់មាន denture អត់មានអីគាត់មាន lip support គ្រប់គ្រាន់អញ្ចឹង case នេះគឺជា simple case ទេដែលយើងគិតថាគាត់ហ្នឹងគឺគាត់បាត់តែថ្មិញទេអញ្ចឹងយើងដាំ implant ឲ្យទៅហើយយើងដាក់តែថ្មិញមកវិញមកគឺយើងអាច support ទាំង lip ហើយនឹង function របស់គាត់បានណាឆ្នេះ maxillary ហ្នឹងគឺគាត់បាត់តែថ្មិញទេប៉ុន្តែបើយើងមើលខាងក្រោមវិញគឺយើងឃើញ rich ហ្នឹងគឺមួយចំហៀងវានៅថ្មិញមួយចំហៀងទៀតគឺ composite defect អញ្ចឹង case បើយើងឃើញ case អញ្ចឹងគឺជាបទពិសោធន៍របស់ខ្ញុំគឺយើងកែបើមាន available bone គ្រប់គ្រាន់គឺយើងដកអាថ្មិញដែលវាhopeless tint ហ្នឹងហើយយើងកែវាឲ្យទៅជា composite defect តែម្ដងព្រោះនៅពេលដែលយើងធ្វើ full restoration យើងត្រូវការflat យើងត្រូវការបូន flat ដើម្បីឲ្យយើងធ្វើ prototype មកវាអាច cleansable កាលណាយើងទុករឹសថ្មិញហ្នឹងឬក៏យើងដកឲ្យយើងអត់បានsmooth bone ឲ្យស្អាតទេ prototype ដែលយើងដាក់មកវាឡើងចុះហើយយើងទៅចាំតាកាលណាបាត prototype ហ្នឹងបាត prototype screw retain ហ្នឹងកាលណាវាឡើងចុះ អ្នកជំងឺគាត់ពិបាក clean ណាអញ្ចឹងជា recommendation គឺគេឲ្យ flat គាត់អាចប្រើ floss អាធំហ្នឹងទៅគាត់ clean ស្រួលសម្អាតអូខេអញ្ចឹងផ្នែកខាងធ្មេញខាង mandible យើងធ្វើជាគាត់មាន composite defect ចឹង treatment plan របស់យើងគឺយើងធ្វើជា PFM ឬក៏ PFZ ដោយអត់មាន gam ទេផ្នែកខាងលើហើយយើងអាចដាំ implant ពី4 5 6 7 8តាមលទ្ធភាពហើយតាម available បងហើយតាម skill របស់យើងប៉ុន្តែត្រូវចាំថាធ្វើម៉េចឲ្យមានAP spread កាន់តែធំកាន់តែល្អហើយ mandible គឺយើងធ្វើ profile prosthesis ហើយយើងធ្វើ screw retain ហើយយើងដកធ្មេញចេញហើយយើង smooth bone ហើយយើងដាំតែ4 implant ទេហើយជាធម្មតានៅធ្មេញខាងក្រោម whenever possible គឺខ្ញុំប្រើតែ4 implant ទេអញ្ចឹងcase នេះយើងធ្វើ planning case នេះវាពិសេសបន្តិចដោយសារកៅនៅ mandible នេះបើសិនជា 3D យើង quality ល្អយើងត្រូវរកមើលកៅ anterior loop អញ្ចឹងជួនកាលយើងឃើញmental foramen នៅកន្លែងហ្នឹងឯងប៉ុន្តែloop របស់វារុនmandible រុន mental foramen ហ្នឹងវាអាចមកខាងមុខនេះរហូតដល់7ទៅ10 មីលីម៉ែត្រហើយកាលណាយើងមើលអាហ្នឹងអត់ច្បាស់យើងគិតថា mental foramen នេះយើងដាំ implant មកនេះអាហ្នឹងត្រូវចំនេះហើយត្រូវចំ mental loop ហ្នឹងហើយអញ្ចឹងវាអាចធ្វើឲ្យអ្នកជំងឺស្ពឹកហើយមួយទៀតគឺខ្ញុំចំណាំទៅធ្វើគឺខ្ញុំមើលអាហ្នឹងហើយខ្ញុំបើក flap មកខ្ញុំវាស់ជាក់ស្ដែងហ្មងយក periodontal prop ខ្ញុំលូកចូលតាម mental foramen ហ្នឹងខ្ញុំវាស់ប្រវែងវាជាក់ស្ដែងខ្ញុំវាស់ប្រវែងជាក់ស្ដែងបានខ្ញុំតាម implant កិច្ចអាហ្នឹងអូខេហ្នឹងគេហៅ anterior IDN loop ហើយខាងលើវិញឆ្អឹងនេះយើង resolve តិចតែអញ្ចឹងយើងត្រូវការ sinus slip internal sinus slip ខ្លះដើម្បីយើងអាចដាំ implant មកដល់ខាងខូចហើយនេះជា planning របស់ខ្ញុំនេះជា plan ទេមិនមែន implant ដែលដាំហើយទេខាងក្រោយនេះខ្ញុំ check មើលទៅមាន available bone យើងអាចដាំ8 មីលីម៉ែត្របានអញ្ចឹងយើងដាំដល់ខាងក្រោយនេះដើម្បីយើងមិនបាច់ធាល implant ទេព្រោះយើងវាកន្លែងនេះវា anterior loop វាខ្លាំងចំណែកខាងនេះដោយសារបូននៅកន្លែងនេះវាអត់សូវមានអញ្ចឹងយើងធាល implant នេះជា surgery ផ្នែកខាងលើហើយគេនេះដោយសារយើងទៅធ្វើ bone graft ខ្លះhorizontal bone graft ខ្លះអញ្ចឹងយើងអត់ធ្វើ immediate loading ទេimplant នេះយើងដាំតែ5គ្រាប់ទេប៉ុន្តែយើងបាន AP space ល្អ AP space ហ្នឹងបានន័យថាកាលណា implant យើងដាំទៅកាន់នៅខាងក្រោយហើយអានេះខាងមុខនេះមកកាន់នៅខាងមុខប្រវែង AP space នេះកាន់តែធំកាលណាប្រវែង AP space នេះកាន់តែធំយើងកាត់បន្ថយ cantilever ហើយកាលណាកាត់បន្ថយ cantilever យើងកាត់បន្ថយ risk ជាមួយនឹង prosthetic complication ចំណែកខាងក្រោមវិញនេះជា surgery នេះជាខាងឆ្វេងយើងដាំ teal implant ហើយយើង smooth bone ខ្លះនេះជារបៀបដាំ teal implant អញ្ចឹងមុននឹងដាំហ្នឹងយើងត្រូវវាស់មើលពីតើអ្នកជំងឺគាត់អាចហាមាត់បានធំប៉ុណ្ណាអញ្ចឹងខាងក្រោមនេះក៏យើងធ្វើ delay loading ដែរដោយសារយើងដាំ implant បានខ្លីហើយមួយទៀតអ្នកជំងឺនេះគាត់ស៊ាំជាមួយនឹងការអត់ធ្មេញហ្នឹងរយៈពេលយូរមកហើយអញ្ចឹងយើងគិតថាគាត់មិន request ផ្ដោះសន្នទេយើងអាចចរចាជាមួយគាត់បានហើយនេះជា 10 week post off ក្រោយពី10អាទិត្យក្រោយមករយៈពេល2ខែជាងអញ្ចឹងជាធម្មតាក្រោយពីរយៈពេលចាប់ពី8អាទិត្យក្រោយមកឬក៏10អាទិត្យហ្នឹងយើងអាចសម្រាប់ edentulous ស្អាត dương trâu thưa temporary đầm bay dương đi muối dương cao thưa bone training tí pí đầm bay dương qua mơ aesthetic dương miền tây cái xem tiệt chẳngផ្នែក prosthetic នេះគឺ Dr. វិទូ Dr. ខ្ញុំគាត់ជាអ្នកធ្វើចឹងយើងមើល healing soft tissue បានល្អហើយនេះជាអ្វីដែលយើងចង់បានយើងមើលយើងដាំ5 implant មែនប៉ុន្តែយើងបាន AP spread ហ្នឹងនេះជា AP spread អ្វីដែលខ្ញុំចង់និយាយហ្នឹងគឺវាធំនេះគេហៅ P implant នៅខាងក្រោយគេយើងវាស់ពីហ្នឹងមកខាងមុខមកចឹងវាបាន AP spread ធំល្អហើយនេះជាខាងក្រោម10ទឹកក្រោយមកដែរចឹងគាត់ក្នុងគេនេះគាត់ធ្វើ temporary ធ្វើអីផ្សេងច្រើនដែរប៉ុន្តែខ្ញុំដោយសារយកមានពេលខ្ញុំកាត់ទៅ final តែម្ដងទៅនេះខាងក្រោមខ្ញុំមាន mistake តិចដែរដោយសារខ្ញុំ smooth bone នៅខាងក្រោយនេះអត់សូវបាន flat ល្អចឹងយើងមើលយ៉ាង curve ឡើងមកបន្តិចចឹងជា recommendation ខ្ញុំឲ្យ smooth ឡើងឲ្យបានច្រើនតិចទៀតហើយក្នុង case នេះដែរយើងធ្វើ final restoration ជាមួយនឹង titanium framework gum composite ហើយនឹង PSZ zirconia zirconia ហ្នឹងផ្នែកខាងមុខហ្នឹងយើងអាចធ្វើជាបើសិនបើនេះទៅយើងអាចវា lab ceramic តិចទៅផ្នែកខាងក្រោយនេះយើងអាចធ្វើជា full monolithic zirconia អញ្ចឹងfinal នេះជា final outcome position implant នេះនៅកន្លែងនេះវារៀងខុសបន្តិចចឹងយើងមើលកាលណាយើងដាំទៅអត់សូវបានចំល្អយើងធ្វើ cement retain វាពិបាកបន្តិចតែគេនេះយើងធ្វើ cement retain យើងធ្វើដូចជា3 section 3 bridge អូខេនេះជា final x-ray ហើយ case នេះជាបើគិតមកដល់ឥឡូវប្រហែលជាអាចចូល2ឆ្នាំអីហើយ case នេះអញ្ចឹង patient គាត់ happy ក្រោយពីគាត់អត់ធ្មេញរយៈពេល10ឆ្នាំជាងក្រោយមកនេះជា final outcome ហើយលោកគ្រូពេទ្យខ្ញុំគាត់បានធ្វើវីដេអូដែរយើងមើលវីដេអូបន្តិចទៅដើម្បីខ្ញុំសម្រាប់បន្តិចដែរយើងគាត់ធ្វើ smile design ហើយខាងលើគាត់ដាំថ្មិញ5 គ្រាប់6 គ្រាប់សំទោសអូខេបាទសុំទោសខេមុនមិញមិនមែន5 គ្រាប់ទេ6 គ្រាប់ប៉ុន្តែដូចខ្ញុំនិយាយចឹងចាប់ពី4 គ្រាប់បាន 5 គ្រាប់បាន 6 គ្រាប់បាន 8 គ្រាប់បានវាចំនួននៃគ្រាប់ថ្មីហ្នឹងវាអាស្រ័យទៅលើ finance របស់អ្នកជំងឺវាអាស្រ័យទៅលើតើ case នឹងយើង select ធ្វើ immediate loading ឬក៏អីផ្សេងទៀតអូខេសុំទោសខាង admin ខ្ញុំនៅសល់ពេលប៉ុន្មានទៀត ដើម្បីខ្ញុំអាចស្រាយ presentation ខ្ញុំទៅលឿនឬក៏យឺត Alo admin ខ្ញុំសល់ពេលប៉ុន្មានទៀត
ចាំតិចលោកគ្រូ
បាទ
10 នាទីលោកគ្រូយើងសល់ពេល 10 នាទី
10 នាទីហ៎
បាទ
អូខេអូខេអញ្ចឹងខ្ញុំប្រហែលជាយើងបានតែ 3 case នេះទេខ្ញុំ plan 4 case នេះជា final case ហើយខ្ញុំគិតថា case ហ្នឹងវា complex ដែរហើយវា bone មកគិតទៅមានតែ zone 1 ទេប៉ុន្តែខ្ញុំក៏មាន mistake ខ្លះដែរដែលខ្ញុំចង់បង្ហាញនៅក្នុង case នេះ case នេះគាត់មកឆ្នាំ 2014 គាត់មកគាត់មាន complete denture ខាងលើហើយនៅខាងក្រោមគាត់ប្រើ fix ហើយនឹងគាត់សល់ថ្មិញខ្លះយើងមើលថ្មិញខាងក្រោមរបស់គាត់ខាងមុខហ្នឹង 4-5 ខួបខាងមុខហ្នឹងវា mobile ហើយ complete denture គាត់ខាងលើហ្នឹងគាត់ថាគាត់ញ៉ាំបានស្រួលទេអញ្ចឹងគាត់ចង់ធ្វើខាងក្រោមជាថ្មិញជាប់អញ្ចឹង case នេះដោយសារបើយើងមើល 3D ទៅថ្មិញផ្នែកខាងក្រោមហ្នឹងខាង bone ខាងមុខហ្នឹងសឹងតែអស់ហើយអ្វីដែលខ្ញុំ plan កាលនោះ2014ហ្នឹង6ឆ្នាំមុនហ្នឹងគឺ remove ថ្មិញហ្នឹងទាំងអស់ហើយយើងដាំ immediate implant ហើយយើងដាក់បណ្ដោះអាសន្នភ្លាមហើយខ្ញុំមាន mistake មួយហើយចាំខ្ញុំប្រាប់ក្នុង case នេះខ្ញុំ remove ថ្មិញហើយខ្ញុំ flatten bone ខ្ញុំ flat bone មកកភ្លូដែរហើយខ្ញុំដាក់ immediate temporary នេះវាអត់ស្អាតទេនេះជាខ្ញុំថតមើលភ្លាមខ្ញុំដាំ 5 គ្រាប់ហើយយើងមាន AP spread មកល្មមដែរហើយក្រោយពីជាមួយរយៈក្រោយមក3ទៅ4ខែក្រោយមកខ្ញុំកាលខ្ញុំធ្វើ temporary គឺខ្ញុំធ្វើ screw retain ប៉ុន្តែដល់ខ្ញុំកែទៅជា final restoration វិញខ្ញុំដូរទៅជា cement retain វិញខ្ញុំអត់យល់ពី protein ហ្នឹងខ្ញុំគិតថា case នេះខ្ញុំគ្រាន់តែខំពុំធម្មតាខ្ញុំ send ទៅ lab គាត់ធ្វើ PFM ធម្មតាប៉ុន្តែយើងក៏លេច back ទៅវិញគឺ case នេះខ្ញុំបានបំផ្លាញ soft tissue បានន័យថាយើងកែពី teeth defect ទៅជា composite effect ប៉ុន្តែដល់ពេលយើងដាក់ថ្មិញមកវិញយើងដាក់តែថ្មិញធម្មតាអញ្ចឹងគឺយើងអត់បានបើគិតពីរឿង function case នេះមាន function ប៉ុន្តែគិតពីរឿង aesthetic គឺគាត់អត់មាន aesthetic ទេគឺគាត់បាត់ lip support ប៉ុន្តែកាលជំនាន់ហ្នឹងខ្ញុំក៏មិនគិតថាវាជានឹងជា serious problem ដែរហើយ patient ក៏គាត់ happy នឹងប៉ុណ្ណឹងដែរអញ្ចឹងក្នុង case នេះខ្ញុំ plan របស់ខ្ញុំគឺខុសហើយ2ឆ្នាំក្រោយមកដោយសារខាងក្រោមរបស់គាត់ហ្នឹងសំទោសខាងលើរបស់គាត់ហ្នឹងគឺ rich វា resolve មែនតើណា rich resolve មែនតើអញ្ចឹងក៏ denture របស់គាត់ហ្នឹងដាក់ទៅវាអត់សូវបានជាប់ល្អងាយរបូតអញ្ចឹងក៏គាត់មក consult មួយសារទៀតដើម្បីធ្វើថ្មិញខាងលើហើយគាត់ចង់បាន fix ប៉ុន្តែបើយើងក៏លេខមើល bone របស់គាត់ available bone អញ្ចឹង case នេះយើងមើលមួយសារទៀតខ្ញុំភ្លេចបញ្ជាក់ criteria ទី1គឺគាត់ composite effect យើងដឹងស្រាប់ហើយព្រោះគាត់ប្រើ denture ឥឡូវយើងមកមើល bone វិញម្ដង available bone របស់គាត់នេះគឺជា available bone គឺស្ដើងមែនតើដូច្នេះ bone របស់គាត់គឺ zone 1 ហ្នឹងមានតិចតួច zone 1 zone 2 ហ្នឹងមានបែរតិចតួចដែរ zone 3 sân tại ọt cứ như đúng đã bị mũi tới 4 mm chân còn bạn từng zone 1 zone 2 និង zone 3 ấy ní chỉ bây giờ mưa 3D ទៅគឺមានប្រហែលជា 1 mm ទៅ 2 mm ប៉ុណ្ណឹងប៉ុន្តែបើយើងអាចធ្វើ sinus slip បានបើយើងអាចធ្វើ sinus slip បានបូកជាមួយនឹង available bone នៅ zone 2 តិចតួចទៀតយើងអាចបង្កើត zone 2 ហើយនិង zone 3 ឡើងវិញបានដូច្នេះខ្ញុំគិតថា case នេះយើងអាចធ្វើជា fix បានអញ្ចឹងខ្ញុំ plan ជាមួយអ្នកជំងឺគឺយើងធ្វើ sinus slip ហើយយើងដាំ implant 8 គ្រាប់ព្រោះជាធម្មតា case ដែល sinus slip quality របស់ bone គឺយើងអត់សូវបានល្អ quality ភាគច្រើនយើងបាន D3 ឬក៏ D4 ហើយយើងត្រូវដាំ implant ថែមនៅកន្លែងម្ដុំ zone 2 មួយទៀតដើម្បីបង្កើន AP spread អញ្ចឹងយើងធ្វើ sinus slip implant placement ហើយនឹង plan ចុងក្រោយគឺ final process គឺប្រភេទprotein ដែលមានញ៉ាំយើងហៅ profile prosthesis នេះខ្ញុំសុំលឿនបន្តិចទៅដោយសារយើងផ្សល់ពេល10នាទីយើងយក bone ពីចកាខាងក្រោមដោយសារ bone ពីចកាខាងក្រោមហ្នឹងវាជាប្រភេទ quality ភាគច្រើនគឺ D2 អញ្ចឹងយើងកាត់មកពីខាងក្រោមមកយើងប្រើ piezo ហើយយើងកាត់មកនេះគឺដើម្បីយើងយកមកកិនវាហើយយើងមិចជាមួយនឹង Cerabone នៅពេលដែលយើងបាន autogenous bone ហើយយើងមិចជាមួយ Cerabone វាបង្កើនជា osteoconductive នឹងបានល្អអញ្ចឹងខ្ញុំប្រើ window technique សម្រាប់ sinus slip នេះយើងកាត់ជាមួយ piezo មកហើយយើងកាលណាយើងកាត់ឲ្យវាស្អាតមកយើងបើកមកវិញយើងដាក់ bone graft ហើយយើងបិទវាទៅវិញយើងដាក់ window នឹងទៅវិញអញ្ចឹងនៅពេលដែលយើងប្រើ technique នេះយើងមិនបាច់ប្រើ membrane ទេព្រោះ window នេះវាដើរតួដូចជា membrane វាជាអ្នក cover sinus slip និង window sinus slip ហ្នឹងអញ្ចឹងយើងបិទflap មកវិញមកនេះខ្ញុំធ្វើទាំងសងខាងនេះជាមុនធ្វើហើយនឹង case នេះក្រោយពីធ្វើឲ្យភ្លាម sinus slip ហើយខ្ញុំនេះជា implant ខ្ញុំដាំថែមមួយគ្រាប់ទៀតនៅខាងក្រោមដើម្បីខ្ញុំបង្កើនហៅ AP spread តាម implant ខ្លីមួយគ្រាប់ទៀតហើយអ្នកជំងឺហ្នឹងក៏គាត់ទៅវិញប្រហែលមួយឆ្នាំក្រោយមកអញ្ចឹងគាត់មកវិញឆ្នាំ2017យើងដាំ implant នៅពេលដែលខ្ញុំបើកដាំ implant យើងបាន quality របស់ bone ហ្នឹងល្អគឺយើង drill ហើយវាមាន bleeding quality bone ប្រហែលជាខ្ទង់ D2 អញ្ចឹងអានឹងជាអ្វីដែលយើងចង់បានហើយយើងដាំ implant សម្រាប់ case ដែល edentulous ហើយយើង delay loading ចេះយើងដាំវាឲ្យ subcrestal ខាងក្រោមនឹងអាច2 mm អីចឹងទៅដើម្បីនៅពេលដែលយើងធ្វើ subcrestal ហើយយើងក្រោយពីរយៈពេល2អាទិត្យក្រោយមកយើងអាចដាក់denture ឲ្យអ្នកជំងឺប្រើបានដោយវាអត់ trauma ទៅដល់ implant របស់យើងឯងអញ្ចឹងគឺ bone នឹងជាអ្នក protect អូខេយើងឃើញ subcrestal មែនទេគឺ subcrestal ឡើងខ្លះ2 mm ឡើងខ្លះអីចឹងមកហើយនេះគឺគាត់មកវិញមួយឆ្នាំក្រោយមកខ្ញុំធ្វើ second stage ហើយយើងកន្លែង second stage នេះយើងញែក soft tissue នេះ keratina នេះមកខែបានល្អមកយើងដើម្បីឲ្យវាមាន implant របស់យើងវា stable បានល្អអញ្ចឹង protein នេះ Dr. Vitu គាត់ជាអ្នកធ្វើដែរ impression ហើយគេនេះយើងប្រើ titanium framework នេះយើង send data ទៅខាង lab នៅវៀតណាមដែរដើម្បីគាត់កាត់ទាំងលើខាងក្រោមទាំងលើទាំងក្រោមហើយក្នុង case នេះដោយសារខ្ញុំចង់កែ mistake របស់ខ្ញុំកាលមុននៅផ្នែកmandible នេះដែលកាលមុនយើងធ្វើ protein យើងជា PFM ធម្មតាទេប៉ុន្តែក្រោយពីសិក្សាឡើងវិញជាមួយ Brazon ដល់អីមកយើងទៅធ្វើ profile protein យើងត្រូវដាក់កម្មដាក់អីឡើងវិញ ចឹងខ្ញុំធ្វើទាំងលើទាំងក្រោមនឹងមកយើងកាត់ជា titanium framework ហើយមកដល់នេះយើងដើម្បីកាន់តែ make sure ទៀតយើងអាចប្រើ wax ដើម្បី build gum ឡើងវិញហើយយើងធ្វើ temporary mock up អីចឹងមកហើយយើង low ហើយអាចធ្វើ smile design អីបន្ថែមទៀតដើម្បីឲ្យ labo របស់យើងគាត់អាចមានតនន័យគ្រប់គ្រាន់ដើម្បីគាត់អាច produce ជា crown នេះផ្នែកខាងមុខតាក់ទង aesthetic យើងធ្វើ cutback technique សម្រាប់ build ceramic ខាងក្រោយយើងប្រើ full monolithic zirconia អញ្ចឹងនេះក្រោយពីដុតចេញមកភ្លាមហើយផ្នែក gum នេះខ្ញុំbuild ជាមួយនឹង composite ប៉ុន្តែក្នុង case នេះអ្នក build gum នេះ build អត់បានស្អាតល្អទេហើយនេះជា final restoration ដែលដាក់ក្នុងមាត់អញ្ចឹង patient គាត់ happy គាត់បាន profile process ខាងក្រោមនេះគាត់លើកតម្រង់បបោមាត់គាត់ឡើងវិញហើយបញ្ជាប់ទាំងលើទាំងក្រោមហើយគេនេះខ្ញុំ follow up គាត់ទៅឥឡូវហ្នឹងប្រហែលជាគាត់ដល់ឥឡូវហ្នឹងប្រហែលជាចូល7 ឆ្នាំដែរហើយគាត់ happy ហ្នឹងអាហ្នឹងចឹងគឺ titanium framework gum composite និង zirconia crown បាទហើយក៏អរគុណច្រើនដែរចំពោះការយកចិត្តទុកដាក់ស្ដាប់ហើយបើមានសំណួរអីអាចសួរ direct របស់ខ្ញុំផ្ទាល់ឬក៏សួរនៅកន្លែងយើង discussion នេះកន្លែងណាដែលខ្ញុំឆ្លើយអត់ចេញខ្ញុំសុំតែឆ្លើយអត់ចេញបាទហើយនេះជា advance course របស់ខ្ញុំដែលខ្ញុំធ្វើមួយឆ្នាំម្ដងទៅ2 ដងដែរបាទអញ្ចឹងអរគុណច្រើនទៅអ្នកទាំងអស់គ្នាដែលត្រង់តាមស្ដាប់នៅ lecture របស់ខ្ញុំបាទអរគុណ
បាទអរគុណច្រើនលោកគ្រូអរគុណខ្ញុំមានសំណួរ2ពី participant ហើយនិងមួយពីខ្ញុំប៉ុន្តែខ្ញុំសូមសួរខាង participant មុនទៅទី1ហ្នឹងគាត់សួរថាបើសិនបើយើងប្រើ temporary ហ្នឹងវាប៉ះពាល់ទៅដល់ stability primary stability ហើយនឹងប៉ះពាល់ទៅដល់ soft tissue របៀបមិនដែរគ្រូសូមគ្រូជួយបញ្យល់កន្លែងនេះ
យើងចង់និយាយពី immediate loading ឯងពេលយើងដាក់ថ្មិញភ្លាមៗឯង
អត់ទេប្រហែលខ្ញុំគាត់ចង់និយាយពី temporary លោក
temporary
ប្រហែលជា immediate loading ប្រហែលជា immediate placement
គាត់ប្រហែលជាចង់និយាយអំពីtemporization របស់លោកគ្រូធ្វើនៅលើ screw retain temporization នៅលើ loading immediate ហ្នឹង
បាទមុននឹងយើងទៅចាំថា full identiless case យើងមិនធ្វើ immediate loading គ្រប់ case ទេអញ្ចឹងយើង select case យ៉ាងម៉េចក្នុង case ដែលយើងអាចដាំ implant បានវែងចាប់ពី10 mm ឯឡើងទៅ10 mm ឬក៏13 mm ឯឡើងទៅហើយ implant ដែលយើងដាំហ្នឹងត្រូវមាន primary stability ល្អដូច case ខ្ញុំមួយដែលខ្ញុំដាំលើក្រោមហ្នឹង primary stability ខ្ញុំដាំអត់បានល្អហើយខ្ញុំដាំហ្នឹងimplant បានខ្លីទៀតអញ្ចឹងគឺខ្ញុំ delay loading ហ្នឹងយើងអាច10 អាទិត្យឡើងទៅយើងអាចតេស្តជាមួយនឹង temporary ឡើងវិញអញ្ចឹង immediate loading not for every case ហើយចំពោះ soft tissue ផ្នែកធ្មេញខាងក្រោមបើសិនជាយើងធ្វើ immediate យើងដកធ្មេញភ្លាមហើយយើងកាត់បូនហើយយើងដាំភ្លាមភាគច្រើនសុទ្ធយើងបាត់ keratinite ចេញជាបានហើយចំពោះធ្មេញខាងលើយើងអត់សូវមានបញ្ហាហ្នឹងទេព្រោះយើងអាច correct soft tissue បានហើយយើងបើកផ្នែកខាង palatal flap ហ្នឹងយើងទាញវាមកខាងក្រៅផ្នែកខាងបាក់ខលមកខ្ញុំមិនដឹងថាខ្ញុំឆ្លើយទៅសំណួរអ្នកសួរណាអត់ទេណាបាទមានសំណួរអីផ្សេងទៀត
សំណួរពីខ្ញុំម្ដងបងខ្ញុំចង់សួរតាក់ទងទៅនឹងfinal talk របស់ screw internal screw នៅលើ multi unit abutment របស់ screw angle តកតងទៅនឹងដូច30 degree របស់បងហ្នឹងថាតើscrew ពីហ្នឹងមួយចូលទៅដល់ internal connection របស់ implant មួយទៀតនៅ prosthetic screw នៅលើ multi unit abutment ពីរហ្នឹងថប់ដូចគ្នាហើយបើខុសគ្នាប៉ុណ្ណាទៅ
បាទអរគុណភិរមscrew នេះគឺខ្ញុំវាមានយើងអត់អាច set ថាប៉ុន្មាន Newton សម្រាប់គ្រប់ system ទេណាមានវាខុសៗគ្នាទៅតាម system ដូចincone system incone នេះគឺ screw ពី multi unit នេះមក implant នេះសម្រាប់0 degree នេះយើងថកវា20 Newton 30 degree 15 Newton ហើយផ្នែកខាងលើនេះគឺ15 Newton ទាំងអស់ផ្នែកពី screw prosthetic 15 Newton ទាំងអស់ប៉ុន្តែដូច case ខាងក្រោយនេះ case នេះវាមាន MIS implant ផ្នែកខាងក្រោមនេះប្រហែលគ្រាប់នេះដូចខ្ញុំប្រើ MIS 7កាលហ្នឹងខ្ញុំមើល recommendation របស់គេតាមខ្ញុំចាំដូចជា20ទៅ30 Newton ខ្ញុំអត់ចាំច្បាស់ដែរព្រោះ screw pro តែនេះបើយើងមើលមែនតើ screw នឹងវាទូចមែនតើកាលណាយើងអត់មើលសំណួរនឹងល្អកាលណាយើងអត់មើល recommendation គេល្អអត់មើល recommendation របស់គេបានត្រឹមត្រូវទេយើងរឹត screw នឹងខ្លាំងពេកអាចបាក់ screw នៅក្នុងហ្នឹងអញ្ចឹងបើសម្រាប់ incone ឯដោយសារខ្ញុំប្រើ system incone ខ្ញុំដឹងហ្នឹងគឺ20 Newton តែ0 degree មួយក្រៅពីហ្នឹងគឺ15 Newton ទាំងអស់ពីលើដល់ក្រោម
មួយទៀតបងប្រហែលជាត្រូវចូលដល់ discussion ហ្មងក៏បានដែរប៉ុន្តែសំណួរខ្ញុំចង់សួរតាក់ទងទៅនឹងcase ដំបូងរបស់បងដែលនិយាយអំពីprosthetic guide នៅលើ CBCT ដែលមាន opacity material បាទក្នុងករណីហ្នឹងguide ដែលថតហ្នឹងពេល surgery បងយកមកធ្វើ cover នៅលើ bone ដើម្បីដាក់ position till implant នៃ apex របស់ implant ឲ្យជៀសចេញពី anterior loop របស់ mental foramen ហ្នឹងឬមួយយ៉ាងម៉េចឬមួយក៏បងគ្រាន់តែជា guide នៅក្នុង thinking របស់បងហើយយកទៅធ្វើតែម្ដងអាហ្នឹងយើងមាន platform guide ហ្នឹងទេ
បាទជា guide នេះយើងត្រូវតែធ្វើប៉ុន្តែនៅពេលដែល surgery យើង flexible ខ្ញុំឧទាហរណ៍ដូចថាបើសិនជាយើងចង់យកយើង flap របស់យើងអត់អាចបើក full ពីក្រោយទៅដល់មុខទេណាបើសិនជាយើងយក guide នឹងមកប្រើ flap របស់យើងអាចកណ្ដាបើកមកផ្នែកខាងមុខនេះដែលយើងចង់ប្រើដែលយើងវាស់ហើយនៅក្នុង implant នោះទៀតថាពីត្រឹមលេខ15លេខ35ដល់45អញ្ចឹងយើងបើកប៉ុណ្ណឹងសិនហើយដើម្បីយើង point មើលថាអ្វីដែលយើងវាស់ position របស់ implant យើងនៅកន្លែងហ្នឹងដែរអត់ហើយយើងចោះមួយជា guide មួយហើយយើងទុកflap ridge ខាងក្រោយនេះជាសម្រាប់ទប់guide របស់យើងឲ្យវា stable ព្រោះបើយើងបើក flap ទាំងអស់យើងយក guide ទៅដាក់អត់ដឹងទេហើយអានេះសម្រាប់ខ្ញុំដោយសារខ្ញុំអូតទៅខ្ញុំexperience ហ្នឹងដែរដល់អញ្ចឹងខ្ញុំភាគច្រើនក្នុង KE Dentistry all on 4គឺខ្ញុំបើកមើល mental foramen ហ្មងរាវខ្ញុំបើកមើលដោយភ្នែកផ្ទាល់កាលណាខ្ញុំមើលឃើញខ្ញុំអាចដាំកិច្ចបានល្អជាងដែលខ្ញុំប្រើ guide ហើយនៅពេលដែលខ្ញុំដាំ implant ហ្នឹងពេលដែលខ្ញុំដាំ implant ហ្នឹងពេលខ្ញុំដាំ implant ហ្នឹងខ្ញុំដាក់ implant final ហ្នឹងខ្ញុំកិច្ចបាន maximum បានដំណើរហើយខ្ញុំឲ្យអ្នកគឺគាត់ខំមើលជាមួយលើហ្នឹងបើសិនជា position នេះត្រង់នេះវាអាចមកដុំ molar ទី1ឬក៏ premolar អីហើយអាហ្នឹងខ្ញុំ happy នឹងប៉ុណ្ណឹង position ប៉ុណ្ណឹងអាហ្នឹងប៉ុន្តែនៅតទៅមុខទៀតពីរំសួរល្អតទៅមុខទៀតយើងអាចធ្វើ surgical guide ឬក៏អី បានល្អអីអានឹងយើងអាចប្រើវាកាន់តែ accurate ជាងនឹងទៀត
បងចំពោះតកតងទៅនឹងanatomy landmark នៅលើ mandible ដែលតកតងទៅនឹង mental foramen ណាតើមាន anatomy landmark ណាមួយដែលកំណត់រវាងdegree នៃ till របស់ implant យើងឲ្យបានជាក់លាក់មួយអាហ្នឹងតាម experience របស់បង
anatomy landmark ចង់និយាយពី
និយាយថាtill implant វាមិនប្រកាសថា30 degree វាមិនប្រកាសថាប្រហែល degree ទៅតាម case មួយប៉ុន្តែខ្ញុំលក្ខខណ្ឌមួយពេលកំពុងតែធ្វើ surgery ហ្នឹងតើបងមានការសម្គាល់បែបម៉េចដែលគួរតែធ្វើតែ till implant នឹងប្រហែល degree តកតងទៅនឹង surgery ពេលកំពុងធ្វើ
ទី1ខ្ញុំអាចរៀបរាប់តិចតួចទី1ខ្ញុំបើក full thickness flap ហើយខ្ញុំដាំ implant ខាងក្រោយមុនខាង distal មុននៅពេលដែលមុននឹងដាំ implant ខ្ញុំត្រូវរកមើល mental foramen នឹងឲ្យឃើញសិនហើយ mental foramen យើងស្រួលរកហើយយើងបើក full thickness flap មកហើយយើងយក periosteal elevator ហ្នឹងយើងបើកតិចមកយើងអាចរកឃើញហើយនៅពេលដែលយើងរកឃើញហើយយើងត្រូវយកពេលយក probe របស់យើងយកមកវាស់មើលលូកមើលខៅIDN ខាងណា loop វាដល់តាណាបើដល់កន្លែងណាមួយហើយយើងយក probe នឹងជា guide ហើយយើងយកឲ្យ implant position របស់ implant ហ្នឹងយើងធាលឲ្យផុតមុខហ្នឹង2 មីលីម៉ែត្រទៀតដើម្បីវា safe distance ហើយអញ្ចឹងហើយសួរថាយើងអាចធាលបានប៉ុន្មានធាលហ្នឹងគឺគេមាន all on 4 guide របស់គេ maximum របស់គេគឺ45 degree ប្រៀបធៀបជាមួយនឹងposition នៃ all on 4 guide ហ្នឹងកាលណាយើងធាលដល់ហួស45 degree យើងអាចវាអត់មាន component ណាដែលកែត្រូវបានទេអញ្ចឹង maximum ត្រឹម45 degree ណាខ្ញុំមិនដឹងថាខ្ញុំឆ្លើយទៅសំណួរដែរអត់ទេប៉ុន្តែ
បាទបងអត់អីហ្នឹងហើយ
បាទ
អ្វីដែលខ្ញុំចង់ដឹង
បាទ
អូខេ
លោកហើយណាបងសុំសួរតិចលោកខ្ញុំសុំសួរពី case ទី2តិចគួរជួយបញ្យល់ពី occlusion របស់អ្នកជំងឺនឹងបានព្រោះអីគាត់ណាមួយយើងប្រើលើ on for ហើយគាត់នឹងមើលទៅបាត់ថ្មិញsevere ទៅដល់ពេលអញ្ចឹងលោកគ្រូគិតថា plan occlusion របស់គាត់ពីដំបូងមកហ្នឹងយើង plan របៀបនេះ
ហើយនេះហ៎
យក group function ឬក៏
គ្រប់ case full របស់ខ្ញុំទាំងអស់គឺខ្ញុំបានប្រាប់គ្រូពេទ្យគឺ anterior guidance ឬក៏ canine guidance final restoration បើ immediate temporary គឺដូច case នេះអញ្ចឹងimmediate temporary គឺ contact តែធ្មេញខាងមុខទេឬក៏ maximum ត្រឹម canine នេះខាងក្រោយគឺដាក់ឲ្យល្អមើលទេអត់មានឲ្យ contact ទេអានឹង immediate temporary ប៉ុន្តែនៅពេលដែល final restoration អានឹងយើងអាចឲ្យ full contact ទាំងអស់ឲ្យអាចក្រោយតិចប៉ុន្តែនៅពេលដែល excursion គឺ anterior guide
អញ្ចឹងមានន័យថាលោកគ្រូអត់សូវកែទៅលើ vertical dimension របស់គាត់បានទេគាត់ណាខាងក្រោយហ្នឹងអត់ធ្វើឲ្យប៉ះគ្នាទេសម្រាប់ on 4ហ្នឹងហើយយើងយក canine guidance ទាំងអស់អញ្ចឹងលោកគ្រូ
vertical dimension យើង guide ពី final restoration ទៅចាំដល់ full case គ្រប់ full case ទាំងអស់គឺយើងអាចដាំហើយទៅដល់ជាខំពុំយកទៅឲ្យ labo ធ្វើបានទេត្រូវតែធ្វើ temporary ហ្នឹងគឺដើម្បី train vertical dimension ថ្មីរបស់គាត់ជា
ពេលប៉ុន្មានដែរលោកគ្រូ
information ដើម្បីយើង send to lab ជាធម្មតាbone training ចាប់ពី4អាទិត្យឡើងទៅស្ដីលើពេលវេលារបស់យើងពេលវេលារបស់អ្នកជំងឺអីផ្សេងទៀតនៅពេលដែលយើង train គាត់ស្វាំជាមួយនឹងvertical dimension ប៉ុណ្ណឹងហើយបានយើងអាច send ព័ត៌មានហ្នឹងទៅឲ្យ labo យើងយកប៉ុណ្ណឹងហើយរបៀប send ព័ត៌មានហ្នឹងយើងខំពុំហ្នឹងគឺយើងអត់ខំពុំនៅព្រិចធម្មតាទេគឺយើងទៅតែ copy អានេះ copy អា denture របស់គាត់ហ្នឹង copy ឲ្យដូចសឹងថា 90% copy ឲ្យបានទៅដល់កន្លែង labo ហ្នឹងគឺគេ scan យកតែម្ដងគេយកព័ត៌មានហ្នឹងជា guide តែម្ដងអញ្ចឹងបាទខ្ញុំមានខាង labo ខ្ញុំហ្នឹងក៏ខ្ញុំទទួល case full up ពីខាងក្រៅដែរហើយគាត់ខំពុំមកគាត់ send តែពុំមកហើយគាត់ឲ្យ labo ធ្វើថ្មិញ labo នៅលើពិភពលោកអាចធ្វើថ្មិញ full up ដោយខំតែពុំមកបានទេបើអត់មានព័ត៌មានទាំងអស់នេះហើយរបៀបនៃការ copy ព័ត៌មានទាំងអស់នេះខ្ញុំមាននេះផ្សេងទៀតប៉ុន្តែនៅពេលនេះខ្ញុំពិបាកយកមកគឺយើងយក denture របស់គាត់ copy ជាមួយ silicone រឹងហើយរាវទៀតហើយយើងចាក់ជា stone ចេញមក copy ទាំងក្នុងហើយទាំងក្រៅទៀតអញ្ចឹងបាទយើងមានព័ត៌មានគ្រប់គ្រាន់ពួក CAD CAM តែគេកាត់ចេញមកហើយយើងថាអីគ្រាប់ថ្មិញនេះអត់ត្រូវឬក៏bridge នេះអត់ fit ឬក៏អត់អីនៅក្នុងមាត់គេអត់ទួលខុសត្រូវទេអាហ្នឹងហើយតែអត់ទួលខុសត្រូវយើងខាតមកគេហ្នឹងក៏នៅ framework នេះមកគេនេះវាចូល$600 ហើយ$500 អញ្ចឹងបើយើងអត់មានព័ត៌មានតាមត្រូវទេលេបគេធ្វើមកខុសយើងជាអ្នកទួលខុសត្រូវអូខេបាទមានសំណួរផ្សេងទៀតបាទ
ណារ៉ូខ្ញុំគិតថាយើងចូលវគ្គ discussion តែហ្មងណាជាប់គ្នាតែម្ដងទៅ
ហ្នឹងហើយបាទ
មានសំណួរសួរលើpresentation របស់លោកគ្រូក៏សួរទៅហើយ discussion បន្តគ្នាទៅហើយយើងមានពេលប្រហែលយើងប្រកាសហ្មងទៅ
ប្រាប់ speaker មួយទៀតបងឲ្យគាត់បើ
Henry
អត់ដឹងថាគាត់នៅអត់ទេដឹងថាគាត់នៅអត់ទេ
បាទមានស្គាល់នៅតែគាត់នៅតែខ្ញុំមានសំណួរមួយលោកគ្រូ
បាទ
លោកគ្រូខ្ញុំចង់សួរពាក់ព័ន្ធមួយ sinus level លោកគ្រូ
បាទ
ខ្ញុំចង់សួរ
ខ្ញុំសុំទោសខ្ញុំស្ដាប់អត់លឺ
ខ្លះបាទ
ខ្ញុំសុំទោសខ្ញុំស្ដាប់អត់លឺខ្ញុំស្ដាប់អត់លឺសំណួរ
ជួយថែមនៅក្នុង chat ទៅអ៊ីនធឺណិតមានបញ្ហាទេដឹង
ខ្ញុំស្ដាប់អត់លឺសំណួរ
ក៏ដកគឺអាចជួយឆាត
Hello ខ្ញុំសួរលោកគ្រូលឺអត់លោកគ្រូ
បាទលឺអូន
លោកគ្រូខ្ញុំចង់សួរសំណួរមួយដែលពាក់ព័ន្ធមួយ sinus leaf លោកគ្រូខ្ញុំចង់សួរថាតើ sinus leaf យើងអាច immediate implant បាននៅពេលដែលយើងsinus ហើយភ្លាមបានអត់លោកគ្រូ
immediate implant ឬក៏ immediate loading ចង់និយាយ loading យើងចង់និយាយថា
immediate នឹងលោកគ្រូនិយាយសិនលោកគ្រូ
immediate implant បានន័យថាយើងដកធ្មេញហើយយើងដាំ implant immediate loading បានន័យថាយើងដាំ implant ហើយយើងដាក់បដោះសន្ននៅលើ implant របស់យើងអូនចង់សួរមួយណា
លោកគ្រូខ្ញុំចង់សួរថានៅពេលដែលលោកគ្រូធ្វើ sinus lift ហើយភ្លាមបន្ទាប់មកយើងដាំ implant នៅលើ sinus lift ហ្នឹងបានអត់លោកគ្រូ
បានន័យថាយើងចង់ដាំ implant ភ្លាមលើក sinus ភ្លាមជាមួយគ្នា
បាទលោកគ្រូ
បាទអាហ្នឹងគេអាស្រ័យទៅលើ available bone ដូចក្នុង case នេះ bone របស់យើងមានតែប្រហែលជា1 mm ទៅ4 mm ទេអញ្ចឹងបើអូនចង់ដាំ implant ភ្លាម implant ហ្នឹង stability វាអត់ល្អទេអាចព ព្រោះ sinus graft ដែលយើងថែមហ្នឹងវានៅទុនហើយយើងទៅដាំ implant ទៀតឲ្យមានតែ1 mm មានអីហើយ case នេះដោយសារខ្ញុំគាត់នៅស្រុកគេអញ្ចឹងខ្ញុំទៅ plan ដាក់ denture back ទៅឲ្យគាត់វិញក្នុងរយៈពេល2 សប្តាហ៍អញ្ចឹងខ្ញុំអត់ដាំ implant បានភ្លាមទេប៉ុន្តែជាទូទៅខ្ញុំ recommend ថាសម្រាប់ case fully edentulous កុំដាំ implant ជាមួយនឹងលើកសៃនេះជាមួយគ្នាលើកសៃនេះសិនឲ្យ bone វានេះល្អហើយបានយើងដាំ implant ហើយដាំ implant ទៅដាំ subcrestal អាឡូអាឡូអាឡូបាទស្ដាប់ឮទេ
ទៅបាត់ទេ Andre
បាទ speaker ម្នាក់ទៀតប្រហែលជាគាត់ល្ងងមើលសម្រាប់ឲ្យមើលទៅដោយសារតែនៅនោះយកជ្រៅអីពី10កន្លះហើយហ្នឹងក្តារយក
ហ្នឹងហើយ
តែ online គាត់នៅ online ដែរបងគាត់នៅ online
នៅតែ
គាត់ថាឲ្យជួយ say goodbye to everyone ដោយសារតែគាត់នៅនោះយកពេក
ទេបាទ
អូខេ
ចង់សួរគាត់ទីគាត់ទៅបាទលោកគ្រូខ្ញុំសុំបញ្ជាក់កន្លែង guidance ទៀតហេតុអីបានលោកគ្រូអត់ជ្រើសយក group function កន្លែងនេះហេតុអីបានជាទូទៅលោកគ្រូយកកន្លែង guidance ទៅ
សម្រាប់ case គ្រប់ case ហ្នឹង
case ទី2លោកគ្រូហ្នឹងហើយគ្រូអីឬក៏ជា guideline របស់ all on 4ឬក៏ all on 5អញ្ចឹងហ្មង
ខ្ញុំសម្រាប់ guideline សម្រាប់ all on 4ហ្មងគឺfunction ថ្មិញតាំងពី temporary រហូតដល់ final ហ្នឹងគឺគេ recommend ឲ្យ anterior guidance និង canine guidance ហើយបាទប៉ុន្តែឲ្យខ្ញុំថាមាន reference អីផ្សេងទៀតអានឹងចាំខ្ញុំមើលឲ្យ
បាទអរគុណ
តែហេតុអីបានយើង
ក្នុងចិត្តនេះខ្ញុំ
ចង់បាន group function
ពួកខ្ញុំគិតថាវា full arch អញ្ចឹងវាវែងអញ្ចឹងបើសិនបើយើងធ្វើ canine guidance វាទប់អត់ជាប់ឬក៏មិនលោកគ្រូខ្ញុំអត់សូវដឹងដែរខ្ញុំចង់ស្ដាប់យោបល់របស់លោកគ្រូ
ខ្លាច
ពួកអី
canine
ខ្លាចវាទប់អត់ជាប់អញ្ចឹងព្រោះវាវែងដែរអាហ្នឹងហើយ
ពេលយើងសាកកលៀសថ្មិញរបស់យើងនៅពេលដែលអ្នកដូចខ្ញុំខ្ញុំមាន canine guidance ពេលដែលយើងកលៀសទៅពេលត្រូវ canine ហ្នឹងបានន័យថាវា protect canine ហ្នឹងវា protect អាពួកថ្មិញ premolar ហើយ molar ខាងក្រោយហើយអាហ្នឹងវាជួយវិញហ្នឹងមិនមែនទប់អត់ជាប់វាជួយ
បាទអត់អីបាទលោកគ្រូអរគុណច្រើនលោកគ្រូ
បាទអូខេមិញហើយមានសំណួរអីផ្សេងទៀត
ជំរាបសួរលោកគ្រូ
បាទ
លោកគ្រូខ្ញុំសូមបញ្ជាក់មួយទាក់ទងជាមួយ temporary ដែលយើងធ្វើភ្លាមលោកគ្រូអាហ្នឹងគាត់មានបញ្ហាអាចនឹងមានបញ្ហានៅពេលគាត់តាពីឬក៏គាត់មានបញ្ហាអីអត់គ្រូពេលយើងធ្វើ temporary ឲ្យគាត់ភ្លាមពេលយើងដាំហើយភ្លាមលោកគ្រូ
បាទមានបញ្ហាទី1អាច loss of integration បញ្ហាទី2 fracture temporary ហ្នឹងអញ្ចឹងវាមានកត្តាផ្សេងកត្តា loose integration ហ្នឹងខ្ញុំក៏មានបញ្ហាដែរមានពេលខ្លះដាំ all on 4ហើយដាក់ immediate temporary ហើយស្អាតហើយមកវិញ implant គឺអាហ្នឹងអាចមានបញ្ហាហ្នឹងហើយបញ្ហាហ្នឹងវាអាចកត្តាខ្លួនយើងផងកត្តាអ្នកជំងឺផងកត្តាខ្លួនយើងមានដូចជាអីគេដូចជា implant ហ្នឹងវាអត់មាន stability បានល្អទៅ25 Newton អីយើងដាក់ដែរហើយមួយទៀតកត្តាខ្លួនយើងដាំ implant ហ្នឹងវាអត់មាន AP spread nhưng mà đang thấy dương vô là epispace đó nữa dương đam mà này thà implant dương cáo dương đam chởn khộp mấy phần đấy vì epispace nó việc clay về cái này epispace việc clay cầm lăng việc đông màu đó mà cái lại nhỉ hay cả ta này chữ ngữ miền đôi chỉ para function hay không cả đã temporary này chữ ngữ nó cứ temporary nó tại chăm ta mình làm bay full function này temporary nó cứ làm mấy xa vertical dimension làm bay ở nhà chữ ngữ còn ảnh hộp soft food ấy bàn chẳng trong này ha đây có tờ hộp cứ soft food nhưng nhà chữ ngữ class cho mình chữ ngữ mỗi nhầm đam còn đòi có buổi khóp có thực đạp dưỡng có đam hơi phim có từ nhằm tia nhằm ấy mi tại tia mi ấy đó khôi máu phải chỉ biết tất cả máu nhưng fail implant ở mặt của chứng anh nó có ở nhà dục hành đấy hay cả ta môi xây tiết cứ dương reusable not ban cục còn trong thế đại miền composite defect á đối với reusable not ban cục còn temporary đại dương đã nó là việc đào việc bạn cái nào việc bạn temporary việc bạn nói chúng tôi là mối việc thôi implant là bạn là temporary để bạn nó việc thôi implant nó việc tụi rong for tại nhỉ tụi rong for tại implant nó việc fail việc ăn miếng cao cross up splinting chân vì miếng cái ta chờ này dừng ai đặt temporary bán hay chúng recommend tha bởi thân gì dừng start bốn dừng thua delay loading từ hay chăm dừng skill maintain dừng ai thua immediate loading hay dừng select case so bây giờ nhóm mọi người có nhóm select case này so immediate loading
bạn open local
bạn
chẳng ta participant đợt tới miền sầm nổi ấy số đặcการlocal tiệt đấy
mà vậy nghe dưỡng miền sầm nổi ở nhóm cái ta po miền này nhóm mà xe đó đi phải chơi vì mình ban cục quan đang ở bên tay bên sân dưới khoa khát ấy private mà xua time có bàn này
một cú nhóm xung xua sầm nổi muối kẹt tông chuyển muối làm hybrid prosthesis chẳng khối bị ca chọc tới ta dương thời ai quạt instruction làm mấy không ca đẹp là hygiene
chỉ thom mà đã vụ hybrid prosthesis nó cứ dương nhóm phở bị chán cứ từ lờ kê all on 4 rồiคือ maximum all on 6 đây nóក្នុង K ភាគច្រើនចឹងកាលណា all on 4គាត់មាន space ច្រើនដូចក្នុង K ខាងក្រោមនេះគាត់មាន space ច្រើនក្នុងការសម្អាតចឹងគាត់អាចហៅ mega flow ហ្នឹងដាក់ clean នឹងមកចឹងគាត់ clean 4 ដងគាត់ clean 4 ដងគាត់អាចស្អាតបានណាហើយនឹង6ខែគឺមក follow up ម្ដងយើងអាចដោះមើល clean គាត់បន្ថែមទៀតណាហើយបើសិនជាយើងប្រើនេះជា gum composite អញ្ចឹងមកខ្ញុំចូលចិត្តប្រើហ្នឹងដែរ gum composite នេះយើងអាច add time កន្លែងណាដែលវាបាក់បែកកន្លែងណាវា stand ឬកន្លែងណាដែលវាអត់សូវបានល្អហើយវា simple យើងប្រើតែ light cure ប្រើអីចឹងទៅបាទប៉ុន្តែក៏យើងអាចប្រើ material ផ្សេងៗទៀតដូចជា zirconia ឬក៏អីផ្សេងៗទៀតដែរតែវាមាន complication វាមានគុណសម្បត្តិគុណវិបត្តិផ្សេងៗតែគឺprototype របស់យើងដូចខ្ញុំនិយាយហ្នឹងគឺយើងឃើញអត់ចាញ់ហ្នឹងមែនប៉ុន្តែកន្លែងដំណភ្ជាប់របស់វាហ្នឹងគឺវា flat កាលណាវា flat អ្នកជំងឺក៏អាច clean សម្បល់បាន
បានលោកគ្រូអរគុណលោកគ្រូអញ្ចឹងតើ participant យើងមានសំណួរដទៃទៀតទេគាត់អាចសួរទៅកាន់លោកគ្រូបានហើយអាច open mic ខ្លួនឯងបាន
បាទ
មើលទៅដូចជាអស់សំណួរហើយ
បាទដូចជាអស់សំណួរហើយ
ok chứ
Henry miền record bên tai
miền là
record bên tai ok
bàคนย่อมาrecord là cụให้จำติดเทียบไปประจอบ webinar เธอจำเอาก่อน convert เขาจำไปให้ผู้ย่อมโพสในขนม YouTube channel ผู้ย่อมlà cụ เขาจำ share อยู่ public
บ้านโอเค
ចឹងបើសិនជាអត់មានសំណួរទេខ្ញុំសូមបញ្ចប់ webinar របស់យើងហ្មងទៅអញ្ចឹងមុននឹងយើងបញ្ចប់ខ្ញុំសូមអរគុណដល់ speaker ទាំងពីរ Dr. Dioracy ដែលគាត់អត់បាននៅដល់បញ្ចប់ទេដោយសារតែនៅនោះគាត់យប់ហើយអរគុណដល់លោកគ្រូពីរុំដែលចំណាយពេលវេលាដើម្បីមកចែករំលែកបទពិសោធន៍ហើយចំណេះដឹងម្យ៉ាងទៀតចង់អរគុណដល់ participant ដែលពួកគាត់ព្យាយាមចូលរួមហើយ stay ជាមួយយើងរហូតដល់ម៉ោងបាយហី
បាទអញ្ចឹង
ហើយក៏អរគុណដល់ក្រុមការងារ Empowering ដែរដែលពួកគាត់ខំព្យាយាមរៀបចំកម្មវិធីឲ្យយើងទាំងអស់គ្នាបានចូលរួមសិក្សាជាមួយគ្នាព្រោះថានេះជាលើកទី1ដែលពួកខ្ញុំបើកwebinar ជា public ដូច្នេះក៏ពួកខ្ញុំជួបនៅបញ្ហា technical ខ្លះដែរជាពិសេសគឺតាក់ទងជាមួយនឹង email response អញ្ចឹងខ្ញុំសូមអភ័យទោសចំណុចហ្នឹងដែរហើយបើសិនជាទាំងអស់គ្នាមានសំណួរអីអាចដោយលោកគ្រូបាននិយាយមកអញ្ចឹងអាច private message ទៅសួរលោកគ្រូក៏បានដែរអញ្ចឹង recording ពួកខ្ញុំនឹង post នៅក្នុង YouTube channel ក្រោយពីយើងបាន edit
ហើយសួរយោបល់អ្នកទាំងអស់គ្នាថាតកតងទៅនឹង presentation លើកក្រោយចង់ឲ្យមានកម្មវិធីលើកក្រោយតកតងទៅនឹង topic អីអាច suggest បាននៅក្នុង page ឬមួយក៏នៅ chat ហ្នឹងក៏បានដែរ
ឬមួយក៏ discuss ឥឡូវក៏បានដែរឬមួយក៏ថាបើសិនជាក្នុងការ process នៃការចោះឈ្មោះ register មានបញ្ហាអីក៏អាច recommend មកពួកខ្ញុំបានដែរដើម្បីការសម្រួលចំពោះកម្មវិធីលើកក្រោយ
អ្នកទាំងអស់គ្នាគាត់ជួយចូលរួមតិចមកគាត់អាចអានម៉ូដខ្លួនឯងបានហើយទៅគាត់អាច suggest topic គេដែលខ្លួនឯងចង់រៀនអញ្ចឹងហើយចាំពួកយើងជួយសម្រួលគាត់បើសិនតាមលទ្ធភាពដែលពួកយើងអាចធ្វើបានអ្នកណាគេមានយោបល់គាត់អាចអានម៉ូដខ្លួនឯងបាន
ជំរាបសួរលោកគ្រូតកតងនឹងtopic ខ្ញុំចង់រៀនទៅលើ over denture លោកគ្រូ
បាទ
ต้อง implant over denture
បាទ
បាទចង់រៀនពីខ្ញុំហើយចង់រៀនទូទៅទាំងអស់នៅ empowering បើខ្ញុំ over denture ខ្ញុំអត់សូវមាន topic អីដែរខ្ញុំមាន topic to implant over denture ប៉ុន្តែវា very old មែនតើណា topic ហ្នឹងវា 7-8 ឆ្នាំហើយអញ្ចឹងខ្ញុំក៏តែបើសិនជាយើងចង់បានខ្ញុំអាច share ឲ្យចែកជា PDF ឲ្យតែម្ដង
ជំរាបសួរបងខ្ញុំមិនដឹងថាស្ដាប់ឮអត់ទេខ្ញុំប៊ូសារ៉ា
បាទស្ដាប់ឮប៊ូសារ៉ា
បាទខ្ញុំឃើញ topic បងចាប់អារម្មណ៍ប៉ុន្តែវាហាក់ដូចជាជ្រៅចំពោះខ្ញុំព្រោះខ្ញុំអត់ដែររៀនលើpull arch អត់ដែរធ្វើសោះអញ្ចឹងទៅតាមតែខ្ញុំចាប់អារម្មណ៍ចង់រៀនហើយចង់រៀនយូរហើយពីmulti unit department ណាការ select department ហើយជាមួយនឹងការ impression ណាបងអញ្ចឹងបើសិនជាបងមានឱកាសអាចជួយចែករំលែកពីការធ្វើ impression បងនឹងវាមានថាប្រយោជន៍ជាមួយនឹងក្រុមពេទ្យជាមែនទេ
បាទអរគុណប៊ូសារ៉ា
បាទហើយខ្ញុំបើសួរសំណួរទៅថាសំណួរអីដែលសួរខ្ញុំមើលទៅវាជ្រៅពេកខ្ញុំរកសួរអត់ចេញ
បាទ
បាទបង
អរគុណប៊ូសារ៉ាចំពោះtopic នេះបើយើងគិតថាឲ្យរៀនវិញកាលខ្ញុំបរៀនដូចជាចិត្ត3ថ្ងៃបានយើងបាទចិត្ត3ថ្ងៃបានយើង cover វាអស់វាមាន detail ផ្សេងៗទៀតហើយខ្ញុំគ្រោងនឹង run course ហ្នឹងក្នុងខែ 5 ឯប៉ុន្តែដោយសារ COVID ហ្នឹងទៅក៏ដាច់សាច់រឿងអស់ទៅហើយចាំមើលចប់ COVID ហ្នឹងឬក៏អាច run ជា online អីយ៉ាងម៉េចមិនដឹងណា
ចាំមើលចប់ COVID ទៅបើសិនជាបានបញ្ហាខ្ញុំសូមចូលរួមផង
បាទតែបើមានបញ្ហាចម្ងល់អីអត់អីអាចសួរ private មកខ្ញុំក៏បានដែរខ្ញុំឆ្លើយបានគ្រប់សំណួរទាំងអស់គ្រាន់តែសំណួរខ្លះវាអត់ត្រូវសំណួរខ្លះវាយឺតអីអញ្ចឹង
បាទនេះត្រូវការចែកម្លែកវាមានកំហុសខ្លះមានត្រូវខ្លះដើម្បីដើរទៅមុខឲ្យទៅត្រង់ផ្លូវ
បាទខ្ញុំ happy ទាំងអស់ខ្ញុំមិនថាណាប្រើ system អីណារៀនមួយគ្រូណាអីខ្ញុំបាទឆ្លើយទាំងអស់ខ្ញុំអត់បញ្ហា
បាទអរគុណច្រើន
empowering មាន essay អត់ empowering
ឬមួយក៏ participant មាន recommendation ក៏ feedback យ៉ាងណាមកក្រុមយើងដែរ
presentation របស់ខ្ញុំយ៉ាងម៉េចដែរលឿនពេកឬក៏វា boring ពេកឬក៏មិនដែរព្រោះខ្ញុំអត់សូវបាន well prepare
ដូចជាអត់អីទេលោកគ្រូ
ល្មមអត់លឿនផងដូចជាអត់លឿនផង
បាទ
មានតែរយៈពេលពួកខ្ញុំឲ្យលោកគ្រូតិចព័ត៌មានអត់ពេញលេញ
បាទអត់អីទេហើយពួកខ្ញុំ prepare មកនេះគឺលក្ខណៈហៅខ្មែរគេហៅកាប់ដាវសុទ្ធprepare លក្ខណៈ clinic ហ្មងយកមកធ្វើការហ្មងអត់មាន reference មានអីឲ្យនេះហើយអញ្ចឹងយើងអាចស៊ូពាក្យសាយលក្ខណៈហៅកាប់ដាវទៅត
លក្ខណៈ technical
បាទតែអត់អីដូចខ្ញុំនិយាយអញ្ចឹងមានចម្ងល់អីផ្សេងៗអាចនេះបានហើយបើសិនជាអត់អីទេខ្ញុំអរគុណច្រើនទៅភិរម Henry ហើយនឹងក្រុមការងារខ្ញុំឃើញធ្វើការងារបានល្អហើយខ្ញុំប្រហែលជាអាចពឹងពាក់ក្រុមការងាររបស់ Henry ជួយខាងសមាគមដែរសមាគម Implant បាទហ្នឹងហើយបាទនឹងចាំខ្ញុំនឹងតាក់ទងទៅហើយខ្ញុំក៏អរគុណ participant ទាំងអស់គ្នាដែលចូលរួមស្ដាប់ទាំងអស់គ្នាហើយគ្រប់ case ដែលខ្ញុំ share មកនេះយើងអាចយកទៅរៀនសូត្រឬក៏បំពេញចំណេះដឹងដែលខ្វះខាតកន្លែងណាមួយហើយកន្លែងណាដែលមិនល្អមិនយកទេចោលទៅហើយក៏មិនថាអ្វីដែលខ្ញុំយកមកបង្ហាញទេខ្ញុំអត់មាន fail ទេប៉ុន្តែខ្ញុំក៏មាន failure ដែរតែខ្ញុំអត់មានពេលគ្រប់គ្រាន់បង្ហាញ failure ហើយខ្ញុំបង្ហាញបានខ្លះតិចតួចអញ្ចឹងCOVID ក៏ព្រៀនយើងដែរថាយើងក៏វាមិនអាចជោគជ័យគ្រប់គ្រឿងដែរអញ្ចឹងវា failure អាច fail ជាងបាទអាចឲ្យយើងដូរមុខរបរក៏បានហ្នឹងហើយអញ្ចឹងក៏ជូនពរទាំងអស់គ្នា stay safe ហើយបើ clinic វិញធ្វើការដោយប្រយ័ត្នប្រយែងទាំងអស់បាទ
អរគុណច្រើនលោកគ្រូ
បាទអរគុណ
លោកគ្រូ
បាទ
ហើយអរគុណពីផ្នែកម្ដងទៀតក៏តែមុននឹងយើងបញ្ចប់ចង់សូមបញ្ជាក់ថាតាក់ទងជាមួយនឹងលុយដែលទាំងអស់គ្នា pay សម្រាប់ register ហ្នឹងគឺពួកខ្ញុំ collect ហើយពួកខ្ញុំចូលមក cover ទៅលើការចំណាយផ្នែកបច្ចេកទេសខ្លះតាក់ទងជាមួយនឹង IT អញ្ចឹងនៅសល់ប្រហែលគឺពួកខ្ញុំនឹងបរិច្ចាគទាំងស្រុងទៅគណៈកម្មការប្រយុទ្ធប្រឆាំងជាមួយ COVID អញ្ចឹងពួកខ្ញុំគឺអត់រក្សាទុកជា profit ក្រុមទេអញ្ចឹងមានតែប៉ុណ្្នឹងទាំងអស់គ្នាមាន feedback អីអាចជួយ message មកពេកបានឬមួយ message private ក៏បានដែរអញ្ចឹងអរគុណអរ Have a nice day
Bye
Goodbye
បាទអរគុណ
Bye ខ្ញុំបិទទាំងអស់ហ្មងឯណាបង
បាទអរគុណអរគុណទីឌីអរគុណមេនបាយបាយ
អរគុណអរគ្នាបាយបាយអញ្ចឹងខ្ញុំបិទ meeting ហើយបាយបាយ